ทุกท่านนะคะกลับเข้าสู่ IAEA Expert Mission Strengthening Optimization in Radiological Practice นะคะอาทิตย์นี้เป็นอาทิตย์ที่ 7 แล้วนะคะที่เรากลับมาพบกันท่ามกลางวิกฤตของโควิดและรอบ 3 ในประเทศไทยนะคะแต่ The show must go on นะคะท่านที่ยังกักตัวอยู่ที่บ้านหรือว่ามีโอกาสมีเวลายังไงก็อยากให้มาลองนั่งฟังกันนะคะครั้งนี้ก็เช่นเคยนะคะเราก็ได้รับเกียรติจากวิทยากรของ IAEA นะคะดร. Sam Bradyเป็นหัวหน้านักฟิสิกส์นะคะจาก Cincinnati Children's Hospital ซึ่งครั้งนี้เนี่ยคุณแซมอยากจะมาเล่าให้เราฟังถึงในเรื่องของ fluoroscopic แล้วก็ IR dose metric นะคะแล้วก็ how to set up dose alert level นะคะซึ่งก็น่าจะมีประโยชน์แล้วก็สามารถเอาไปใช้ในชีวิตจริงได้สำหรับทั้งนักรังสีแพทย์นะคะแล้วก็นักรังสีเทคนิครวมทั้งนักฟิสิกส์ที่ต้องมาช่วยในการเซตระบบนะคะ Good evening Sam nice to meet you again.And this week is week 7 Vadika for the expert mission in the topic in the theme of strengthening of the optimization in radiological practice. And this week we come back on the fluoroscopic and also IR dose metric and also how to set up the dose alert level. And this week, this is like the week that in Thailand we still have the issue with the COVID things.It's like we have almost 3,000 new patients. Yeah, I think like yesterday is like 2,800 and today and maybe tomorrow gonna hit 3,000. So hopefully things gonna get better soon. So I give the stage for you for the presentation because the show must go on for the expert mission. And the good thing is we have like a record of video so people can come and watch back on this thing.Yeah,
well, thank you. Thank you once again for the invitation to come and speak. And for all my friends there in Thailand, I hope you all stay safe, especially as you're working with those many 3,000 patients. It's sad. I hope one day we get past this crazy COVID virus. But for those of you that have a chance to watch this now, definitely welcome questions at the end.And for those of you that may not have a chance because you're watching the recording, my email address is here. Obviously, we'll be having several more presentations over the next several weeks. And so if we need to maybe have question and answers next week based on fluoroscopy, I think we can be flexible. So I hope everyone stays safe. All right. So as Tanya mentioned,We spoke about fluoroscopy last week, but it was around or centered on image quality. So today we're going to spend the rest of this morning talking about we're going to review dose metrics that are used or common for fluoroscopy. And then at the second session, we're going to talk about how to optimize the radiation dose in fluoroscopy, talking about, of course, diagnostic reference levels and alert levels, as Tanya mentioned.All right, so one bit of just as a question that came up at the end of last week, so I owed you all a little bit of explanation. We talked about using these type of plastic blocks. They're made out of plastic, polymethyl methacrylate, or PMMA, and you can cut them in various different thicknesses and different up from 0.25 inches or 0.6 centimeters. I have my largest is 2-inch thick or 5 centimeters thick. These blocks, when stacked in various different configurations, help to simulate different thicknesses of patient attenuation. So we definitely use this when we're trying to estimate how image quality will change by different patient size And of course, when it comes to radiation, when you put an ion chamber or some kind of dose monitoring device in there, the system will change the radiation output based on the various different thicknesses of plastic. And so the question was, how many of these blocks should I use to simulate various different patients? And here is a table for those of you. So this is in the PDF that will go out. Of course, you can have this and look at it closely. And so you have a couple of columns here. We have the anterior posterior dimension, and then we have the lateral dimension. And then if you take those two values, as you see in this little equation, anterior posterior times lateral, and you take the square root of that, that gives you the effective diameter of a patient. And so these values right here are for a variety of different patient sizes. There are kind of quote unquote equivalent weights and ages. So they're not perfect when you're trying to compare a piece of plastic to a patient's size, weight, and age. But as I'll show you on the next slide, they actually do pretty well. And so if you want to simulate, for example, a 6 or a 7-year-old patient, then you would take 6 inches or 15 centimeters worth of these plastic blocks and place them within the radiation beam of your fluoroscopy system, and it will use the same amount of radiation output as if a similar size 6-year-old patient was on the table. So I use these blocks. In fact, many of my colleagues here in the US, and I know several in Europe, use these blocks. I'm sure even you guys have these and have been using these in Thailand, but they're a phenomenal way they're really simple. They're actually really cheap, easy to make. If you crack or break them, they're really only pennies on the dollar to buy these this plastic. So they're really good and something that you can distribute to a lot of your different hospitals. They're infinitely cheaper than if you go out and buy these types of phantoms, these anthropomorphic phantoms. And so I have these 5 anthropomorphic phantoms of various different patient thicknesses. And what I did is I went and I put them all on the fluoroscopy system, and I turned it on, and I looked at how much radiation output there was. And then I did the same with these blocks. And I compared, so here you have on the x-axis here, the abdomen diameter of these 5 phantoms. That's why you see these 5 markers here. And on the y-axis here, you see the various different thicknesses or stacks of plastic. And what you can see here is it's almost a one-to-one relationship. You can see here the PMMA agrees to better these blocks. They agree to better than 93%. So the fitting coefficient, the regression of 0.999, so it's an excellent fit. And the conversion factor from PMMA blocks to these anthropomorphic phantoms is 0.9336, or roughly 93%. So the point here is these blocks are phenomenal if you want to use them to do dose and image quality optimization in fluoroscopy. All right, so getting to today's topic, dose metrics for fluoroscopy. As we said, even last week with image quality, the metrics we use must be something that are measurable. And so it's the same concept here. We can't really necessarily pick different metrics such as effective dose or others that you can't physically measure with an ion chamber because it's something that we can't validate on the machine. So the first and most important aspect of any dose metric we use for fluoroscopy is something that's measurable. And the second is ideally whatever quantities we choose to track and use for diagnostic reference levels or for alert levels is something that would correlate with risk or correlate with radiation exposure. So potential risk or being able to measure something that would have some kind of way to correlate with future cancer or stochastic risk. And then the other one being radiation output. So something that would affect tissue like the skin burn, hair loss. So your deterministic risk. There are a variety of dose metrics out there. And so here are the most common ones that you will see when we talk about fluoroscopy. I give you the common abbreviation in this column. So maybe out in literature, if you're reading the scientific literature, you'll see them sometimes labeled as one of these. This is the IAEA's abbreviation, and then the International Committee on Radiation Units. And so you can see that they're kind of different. They have some similarities, but I just simply gave you this table so you always have this as a reference. You could always look it up online, but if you would like, it's all in one place right here. So there's a variety of different metrics. What we're going to focus on today for fluoroscopy, for traditional real-time fluoroscopy, we're going to focus on the CAP, or the Kerma area product, the cumulative air Kerma, and this is at that R right there is with respect to the reference point, which I'll talk about, peak skin dose, fluoroscopy time, and then when we actually talk about where we use the C-arm, the fluoroscopy C-arm, on such as interventional systems and even some mobile C-arms, they can actually spin in a programmed way to create a volumetric CT data set. And so in that case, there are a variety of different metrics we'll talk about for that. And we'll get to that at the end of the talk. So I'm just going to move forward. So the first, probably one of the two more popular ones, as I mentioned, is CAP, or the Kerma area product. You will also hear it called DAP, or dose area product. DAP is actually old. It's technically not as correct because we measure air Kerma. So that is why we call it CAP nowadays, but they are equivalent. They are the same. So if you see CAP or DAP, they're the same. What it is it's the sum or integral of air Kerma over the field of view. So whatever field of view you set on your patient while you're doing the fluoroscopy, and you may change it over the course of the procedure, CAP will take into account not only the output, the air Kerma coming out of the machine, but it also takes into account how much of the patient or the area is being exposed. So how do we do this? Well, there's a ion chamber, a CAP meter, that is on basically all of these, especially the interventional systems, but pretty much all of the fluoro units. It's on the collimator head. So this is the X-ray tube down here, and this is the collimator. So it's got the blades that you use for collimation, and then the CAP will sit right on the outside. Here you can see it not on the machine. It's basically just a very large ion chamber, and it's meant to be as large as the collimator. So no matter what size field of view, how big or how small, this ion chamber, this CAP meter, will be able to calculate CAP for you. All right, so CAP is a great way to approximate the total amount of radiation delivered to the patient, which would make sense, right? It's not just the amount coming out, but it's also the amount as it's summed or integrated over the entire area of the patient. It is the dose metric that is most relevant when we consider risk. More specifically, when we consider long-term risk, such as cancer risk. The one downside to CAP is we do not use it necessarily to indicate how much radiation the skin received. It's very hard to back calculate skin dose from CAP. It's possible, but for the most part, we don't use it. When we talk about CAP, we're mostly referring to risk, such as stochastic risk. So CAP typically has units of radiation output, grays, and some area. Meter squared, centimeter squared, millimeter squared, whatever it is, it's an area. You need to be careful. Unfortunately, all vendors use different units. Some may be gray centimeters squared, some may be milligray meters squared, etc. So you have to be careful when you're comparing one vendor to the next in your hospital, or when you have multiple hospitals, which you're doing for diagnostic reference level. You're going to get all of these CAP values in. You will have to do a little bit of math and make sure the units are all the same before you sum them together and do your statistics. So CAP is a very good metric, to use, because it does not change no matter where along the radiation beam when you leave the X-ray tube all the way up to the point where it enters the body, to the skin surface. And the reason for that is, as you may recall from your days back in school, radiation diverges. And so it starts at a source, we consider it a point source, and as it gets farther away, it changes as 1 over the distance squared. So therefore, when you go one distance or one radius out, it's going to have a certain amount of photons that pass through a certain area. But as you go now double that, well, the area has gotten much bigger, so the amount of photons in that same area is more diffuse. And so basically, the amount of photons per unit area will decrease as you go farther away from the source, which is a good thing, right? In the sense that if you're ever near a radiation source, the farther away you get from it, the safer you are because less radiation's hitting you. What's great about CAP is it not only takes into account the fact that radiation changes as a function of distance, but the area that the radiation is exposing also gets bigger. And so those two things cancel each other out. The area gets bigger just as the radiation is getting lesser. And so that is why when we calculate CAP, it is the same at every point as you go away from the X-ray beam. Now, once it enters the body, so once it gets to the patient or the fluoro table, whatever object it first impinges on, now you start getting the scatter. And so CAP will change. CAP is not the same inside the body as it is outside the body. And that's why, as I mentioned, it's really hard to use CAP to approximate skin dose or entrance skin dose, I should be more specific. So how do we use CAP as a way to estimate risk? Well, there are a variety of different correction values. So you can find these out in the literature. I simply listed two. You go out, here's one publication where they provided an average correction factor that will convert your CAP to effective dose. And so they did it for gender, male or female. And then another publication down here where they actually broke it up as a function of body size based on BMI. And so you can see the numbers change a little, not a lot, 0.27, 0.29, down to 0.23, but they do change. And here's the standard deviations. And here you can see the range. Now these ranges, 0.17 to 0.35, I hope that helps you understand that when it's all said and done with, there is a lot of uncertainty when you make these conversions. And so that's why, once again, first of all, effective dose is not patient dose, it's population dose. In other words, you can only ever say that the risk to an individual is the same as if it was another person in that population. And so you're just saying that these 5-year-olds would have, or these 10-year-olds, or these adult males would have this quote unquote risk. And the fact of the matter is there's a pretty good error bar on this because of this range. And so it's a first order approximation to risk. I would never use this as a way to determine if someone's going to get cancer in the future. It's just there's too much error there in your measurement. So the way you can do this, and I gave you a simple example here. This was from a dose from one of our fluoro patients. This is just the dose summary sheet at the very end. You can see in this case, I only captured it for the cone beam CT. They did do one fluoro right in the middle there at 2 frames per second. But for the most part, I only captured just the first few series, which had the X per CT, which is a Philips version of the cone beam CT. And here you can see the system gives you the DAP or CAP, and also gives you the air kerma values, etc. And so here I can take all of these values and I could either sum them all up as just an average, or I could sum them all up as a total. I could average them if I really wanted to, or I could calculate this effective dose for each one of them. But either way, for the most part, you can just make this value, take this value from your dose summary report, find the equivalent conversion factor based on either gender or size, and make a simple multiplication. And it's here, this is just a simple plot where I was doing some work where we were comparing the CT doses from the fluoro C-arm rotation and the CT doses from a standard traditional CT scanner, which we're actually going to talk about later today. And so you can apply these correction values as long as you have a DAP or a CAP. Excuse me. The next dose metric that's very important is the cumulative air kerma. And the R in the subscript stands for at the international reference point, which I'll demonstrate in a second. So the cumulative air kerma at the international reference point is a value that will always be, especially it has to be on the newer scanners, Older scanners, not so much, but basically for the last 10 to 15 years, it's been required by all vendors to show this value on the screen. So while you, the physician or the technologist, as you're operating the machine, you should be able to see the error kerma value in real time. Here's an example of a system that shows error kerma and DAP or CAP in real time. This one only shows the error kerma and then just the total fluoro time. So it just depends on the vendor. They're all different, but the one thing that is going to be consistent is the error kerma value. So what do I mean by international reference point? So in this example, I'm just going to use a C-arm, and this is an interventional system, but I'll show you where the reference point, international reference point is for all types of fluoroscopy systems in a minute. But in every one of the systems, these C-arm systems, you have the detector on one end, of course, and the X-ray tube on the other arm, on the other side. And there's going to be an isocenter. That's the point on these C-arms that the C-arm itself will rotate around a patient. That's the point you want to stick dead center of the patient so that we can get the radiation dose, so we can get the right radiation dose to the patient, good image quality. If you go 15 centimeters from the isocenter towards the X-ray tube, that is the international reference point. It's always 15 centimeters towards the X-ray tube from the isocenter. Now, why is that? Well, the reason for that is if you place that isocenter dead center to your patient, and if we assume an average 30 centimeter diameter or 30 centimeter anterior posterior depth, thickness of a patient, then if isocenter's at center, there would be 15 centimeters from the center to the skin, the entrance skin or the patient's back, if they're laying supine on the table. That is why it's 15 centimeters. It approximates the point where the patient entrance skin dose would be calculated if they were a typical or average person laying supine or prone, I guess, doesn't matter, on the fluoro table. All right, so here I just give a simple list. This is a way for you, every system, every vendor, every configuration out there will have to define its international reference point. It's always defined the same place, but you can see that every system will have a subtle difference just because of the geometry, the size of the machine. And so you need to know exactly where your international reference point is so that you can do some dose calculations, which I'll show in a moment. And so here I just simply listed a few: GE, Philips, a couple Siemens units. These are systems that have international reference points that range from anywhere from 67 centimeters from the focal spot all the way down to about 60 centimeters to the focal spot. So there is a difference. You can't assume it's all the same. It's always different for every machine. Well, vendor, I should say. A value that might be more interesting is the international reference point to the floor. And that's just because not every machine do you know exactly where the focal spot is, but you'd obviously know where the floor is. So if you measure from the floor up to an example, a GE Discovery IGS, it's 92 centimeters from the floor to the international reference point. So here I just gave you some values here. And these values will be important in a little bit when we go to calculate patient's dose, and I'll show you how to do that in a couple slides. So as I mentioned, every type of fluoroscopic system has an international reference point at a different location. You and I know fluoroscopy comes in a variety of different geometries, variety of different flavors. So you have your typical C-arm for your interventional systems, for your cath labs, your cardiac cath labs. For your routine conventional fluoroscopy that's performed in radiology, you'll have either an under-table X-ray tube or an over-the-table X-ray tube. In the case where it's under-table, the international reference point is 1 centimeter above the table. And then in the case of an over-table tube, the value is 30 centimeters above the tabletop. So here you see it's slightly different. In a fixed C-arm, typically found on your mobile units, it is 30 centimeters from the detector. In a mini C-arm, oftentimes used in just ortho, because it's very small part and the C-arm is actually very short distance and small, there is no international reference point. And that's mostly because in these cases, you usually place the anatomy directly onto the detector, in this case an II, but it could be a flat panel too. So as I mentioned, why is the IRP, the international reference point, at 15 centimeters? Well, as I mentioned, if you have a typical patient that is roughly 30 centimeters thick or in diameter, as long as the isocenter is dead center to the patient, then that international reference point is going to give you a pretty good approximation to the entrance skin dose. So the value you see on the monitor gives you a real-time value of how much radiation is exposing the skin. Now, the problem with that is we're not all exactly 30 centimeters thick, and we don't always have the isocenter exactly in the center of the patient. So here you can see two geometries that aren't necessarily anterior, posterior. You see here we're off on an oblique angle. In this case, the isocenter is off centered a little bit. It still works out that the international reference point is basically at the skin line. But in this case, now we've swung it all the way lateral. Isocenter still in the patient, but now the international reference point is actually inside the patient. So the value that you would see on the screen is underrepresenting how much radiation dose you're getting to the skin. Now, if you're a teeny patient, which is more typical for pediatrics, that value, the international reference point, might be outside the body, might be lower, in which case the value you see on the screen is overrepresenting. So you have to know kind of where the international reference point is when you go to do some calculations, if you need to know how much radiation dose the skin and the patient received. All right, so that kind of takes us to the next step, entrance skin dose. So the air kerma at the international reference point, that is not necessarily skin dose. I think we made that point clear. Skin, however, is the organ at risk in fluoroscopy. When we consider the exposure risk, we're basically worried that we're going to cause some kind of tissue reaction. Too high a radiation dose can cause, of course, as you know, epilation or erythema. So the reddening of the skin, necrosis. If it's a high dose, obviously loss of hair. And so we're mostly concerned with how much radiation the skin gets. So we need to make some calculations to convert our cumulative air kerma at the reference point to the air kerma of our skin, so the entrance point. So what we're going to do here is I have an equation, and I'm just going to step you through how to use this equation. This isn't something that necessarily you would do for diagnostic reference levels. This isn't something you would necessarily do for alert levels. This is just something you need to know how to do if you need to make an approximation or a calculation, a determination, if a patient received enough radiation dose that you need to maybe do follow-up for skincare. So this is probably something that usually only the medical physicist would do. Nonetheless, I'm going to give you all the steps for those of you that are interested in making these dose calculations. You'll have them all laid out in these next couple slides. So let's look at this equation and let's see what all the values are. So when you want to consider the dose to the skin, well, we have the air kerma, right? That's the air kerma, the cumulative air kerma at the international reference point. The next thing we need to know is where is the patient with respect to that reference point. So we know where that reference point is. Remember, I gave you that table. You can either measure it from the floor to the reference point or from the focal spot of the X-ray tube to the entrance point. And so we also need to know what the distance is of the patient. So maybe the floor to the table. We need to know how much the radiation attenuation will change as it goes from air exposure, as it enters to the body and goes into the skin. So there is a ratio of how much attenuation will change as it goes from air to skin. And we need to account for the fact that there's a lot of backscatter. In other words, a lot of that radiation, when it hits the skin, some of it's going to penetrate in a little bit and it's going to scatter back out. And so it has the potential, once it goes into the body, to actually come out and dose the dermis layer. And so there is a backscatter component. And then, of course, there's a bunch of things in the path. So if the patient's laying on a table and they're probably laying on some kind of cushion or some pad, well, that table and that pad are going to attenuate the radiation beam. So we need to take into account all of the objects between the X-ray source and the patient. So here's an example. I just randomly grabbed a patient. Here's the fluoro, and what they're doing here is this is the dose summary sheet. A couple of things you'll notice. This was supposed to be animated, so I'm sorry that wasn't supposed to appear quickly at first. You can see a total cumulative fluoroscopy time. So it was a short procedure, 9.5 minutes, not long. Here's the DAP, or excuse me, CAP. Here you can see the units of this are milligray centimeters squared. So pay attention to the units. Here is the cumulative error curve at the reference point, 100 milligray. And it tells you, you know, how many runs and all the fluoro shots and all that. And so here you can see it lists all of the different imaging, and you can see the dose, the error curve value for each one of those, and of course the cap, etc. So the first thing we needed to establish is how accurate is the measure of this error curve at the international reference point. So this is something the medical physicist should be doing probably annually. At least that's something that is required for us as medical physicists here in the US. Don't quite know what the law and rule is for you there in Thailand, but even if it's not required by law, it's something I highly, highly recommend you do a minimum of once a year. And once you go in and you make some measurements, you will establish a correction factor. And once you have that correction factor, you can then correct the value. This error curve value may require a correction to be more accurate. Now, it's important to understand that the vendors, the manufacturers of all of your equipment out there, there is a standard that they must meet to sell their equipment. There's an international standard that's defined by the IEC. They do not require the vendors to be any more accurate than 35%. So the value you see on that screen when you're in there operating could be actually plus or minus 35% accurate. Could be higher by 35% or lower by 35%. So that's why it's very important for the medical physicist to go in and verify that. In fact, they could actually verify it and correct it and make it so it's more accurate on the display. I typically, when I make my measurements, see my systems are usually 5 to 15%. So the reality is, even though they're allowed to go to 35%, most of these manufacturers, they're doing their best to do better than that. So you go in, you make your measurements at the point, you make your measurements with your ion chamber and your cap meter, DAP meter, whatever you've got, and then you compare it to what's on the screen, you do some math, and you can know what your correction factor should be. All right, so now that we can scale our error curve value, let's look at the next point, the distancing. We need to scale this, we need to fix this so that the dose at the reference point is actually referring to the dose at the skin entrance level. So in this machine, it's a Philips machine, the international reference point is 66 centimeters from the focal spot. I should have written that there, from the focal spot. The table is actually 97 centimeters. So that's floor to table. And the interesting thing about this, that's important to know, is most table heights are fixed based on the operator. And so you might not always know what the table height is. When, let's say you have a patient that's gone in, the overall, the cumulative error curve at the end of it's a really, really high number. So you're afraid you need to do some dose calculation to make sure there is no skin effects. Well, nowhere on this does it tell you actually what the table height is. But you actually might know how tall Dr. So-and-so was, who did the procedure. In fact, I have a table in my spreadsheet that tells me the height of all of my physicians, because they all pretty much operate at a certain level. You know, they're not going to operate with the table so high, and they're not going to operate where they have to hunch over. They pretty much always operate the table at a very specific height. So if you don't know the height of the table, you can make an approximation of that if you know who the physician was that performed the procedure. All right, so my machine has a focal spot to floor distance of 26 centimeters. And so obviously I can do a little bit of math here International reference point, 66 centimeters from the focal spot plus 26 centimeters. So, you know, I got, what is that, 80, that's 92 centimeters from the floor. So my international reference point is 92 centimeters. My table is 97 centimeters. So now I know that there's a 5 centimeter difference. So it's actually not at the entrance point of the body. I need to correct that. And I also know that this patient is laying on a 12 centimeter thick pad along with the table. So you do some math, 97 centimeters plus 12 centimeters for the patient or for the pad. So the patient's actually up 12 centimeters, minus it from the floor. So now I have a distance source, the focal spot, to the actual point where it enters the patient. So you can just do some really basic geometry math. You put those values in here. And so you put you know what the source to the international reference point is. Now I know what the source is to the patient's back, or assuming they're supine. And now I know that this value needs to be scaled by 63% or 0.63. Nope, lost our picture there. Got corrupted. Sorry. I'll fix that on the PDF. So now that is fine if it's a simple anterior posterior. But if you actually look at it, in some of these, this patient had an angulation. So now it's going to be either angled, in this case, cranial caudal, or it might be rotated. There might be some angle. So you might have to actually pull out your old geometry, something you probably didn't do since college. But you just need to pull out your sines and your cosines and your tangents and figure out what the actual distance is if it's at an angle instead of directly up and down perpendicular. Now, one of the things that you'll notice, and you can see here, in this case, because this patient they angled it cranial to caudal at 17 degrees, the distance went from, the correction factor went from 0.63 to 0.69. In the grand scheme of things, that's probably not a really big difference. And so in this case, if the angles are kind of small, you could probably just skip that and assume they're all perpendicular. If you have really large angles, then you might need to take into account the angles. All right, we got our image back. So now the next step here is we need to account for the fact that there are attenuation differences from air to soft tissue. This value is pretty much always either going to be 6 or 7%. So it's just one of those numbers you'll memorize. It does depend on the type of KV or in filter and all that. But even when you take into account the half value layer, which is KV dependent and filter dependent, the value is pretty much always somewhere in that 0.06 to 0.07. So just memorize one of those values. The backscatter factor, once again, this does vary. Of course, it would vary depending on the patient thickness. And there's a bunch of different factors that make it change, but the values don't change that much. They're basically 30% or 40%. So 1.3 or 1.4. In other words, the fact that radiation enters the body a little bit and then backscatters back actually increases the radiation dose at the skin level by 30 to 40%. It's actually pretty substantial when you think about it. Where did I get those numbers? Came from this publication. If you're interested in a nice read, it's an old publication, but it's a good one. And then finally, I measured how much my pad is, that patient pad and the table. I measured how much attenuation that is. It reduces the beam by 10%. So taking all of this together, let's now calculate our patient's skin dose. So I have the option here. I can either apply this equation 15 times all the way down this list and then sum it up. You may have to do that if there are large angles. In the end, you probably are safe enough. In our case, they're basically all anterior posterior or just a small angulation cranial caudal. So I'm just going to ignore that. So I have my max value, my total value, my cumulative error kerma. So what I'm going to do is I'm going to use that value times by my correction factor that I had measured for my machine, times by the correction for the distance, times by the correction for the attenuation difference between air and soft tissue or skin, times by the correction for the backscatter, times by the fact that my pad and table reduced the dose by 10%. And so what the machine said on the monitor, what you saw as a physician, if you were the one that did this procedure, you would see 101 milligray at the end of the procedure. The reality is the skin had an entrant skin dose of 84 milligray. So now you know how to do the calculation, but I hope this gives you a value, gives you at least an inkling or an understanding of how that number on that screen actually is not right per se when it comes to the actual patient risk that or dose that they're receiving. It could be higher and it could be lower. It all depends really. Mostly, if you look at all these numbers, the biggest number, the biggest correction is the distance. So if that international reference point had been right on that skin level, this value would probably be a lot closer to 100. All right, so now what happens if you didn't do all of your work with the beam pointed at the patient and that's it, in one place, one location, one skin port? What happens if you moved along the patient's laterally, moving in superior to inferior? What if you angled? What if you rotated and came in laterally? Now what you're doing is you're actually entering the patient through multiple different ports. And so now the skin is getting exposed in multiple different places. So that cumulative error value, cumulative error Kerma value that's listed, that's the total for the entire exam. But now if you look at this one, there's 1, 2, 3, maybe 4, 5, 6, who knows, maybe 7 or 8 different angulations and movements. We need to understand what the actual peak skin dose is, not the total skin dose. Because if you take 10 milligray of dose over here and 100 milligray of dose over here and 50 milligray of dose over here, if you sum it all up, it says here 451 milligray. 451 milligray sounds like a lot, but the peak skin dose might actually, and forgive me, in this example, the peak skin dose is 450 milligray. The cumulative in this would be closer to like 1,000 or 1,500. So the cumulative sounds way higher than it really is. The peak skin dose, though high at 450, is still not at a point where you have to worry about tissue effects. So now we need to take into account all of the different locations. And in this case, where if you have lots of different locations and lots of different rotations and positions, then it's probably not a good thing just to, as I did here, use my 101 all at once and just do all my calculations. In this case, I would actually need to do my calculations at probably 2 or 3 or 4 different locations to figure out where the peak skin dose is. In the most modern scanners, mostly on your interventional and cath type, so your interventional systems that you would find in the IR or cath lab, a lot of them are coming out with these skin dose mapping software. It's an approximation. It obviously, this little ghost of a patient isn't the actual patient. It's just giving you general location of where it's happening. But the better part is, or the most important part here, is it's telling you that of all of the ports, 5, 6, 7, 8 ports, skin ports, this one skin port was the one that got the most dose. And so then you could go in, use your equation, and make all the corrections to see if it really is 451 or maybe higher or lower. All right, next metric, fluoroscopy time. This is the length of time, total time that you are performing or acquiring fluoroscopy. So please understand that it is not the entire time of the procedure. You may do some acquisition runs, some digital subtraction angiograms and DSAs. You may do some spot films, some fluorographic imaging. All of the things I just listed right there are not fluoro, right? And so when you're stepping on the fluoro pedal, you got your pedal, you got your fluoro on one side, maybe you got your high boost or your DSA on the other side. When you're stepping on the fluoro, you'll see that number increment. The minute you let off that and you step on the other one, which is say DSA, and you do a DSA run, your fluoro time is not going to change. And so this is why, unfortunately, fluoroscopy time is not a really good metric, especially for diagnostic reference levels. So why am I even mentioning that? If you have older equipment that's basically 10 to 15 years old, you probably do not have air Kerma or cap values. Just the older equipment didn't really provide this. And I'm talking relatively really old equipment, 10, 15 years old, maybe even older. So if you're still using really old equipment, or if centers within Thailand have older equipment to do your diagnostic reference level, of course, you're going to want to collect CAP and error kerma, your cumulative error kerma at the reference point. You may need to do some fluoroscopy, may collect fluoroscopy time. Now, you may have sufficiently enough modern equipment that all of your major centers and even like your community centers don't have old 10, 15, 20-year-old equipment, that I would say don't even worry about collecting this. It's a metric that is difficult to use because it doesn't take into account frame rate. So if you're using 30 pulses per second versus 15 versus 7.5, the dose of the patients are so much different in each of those scenarios, but fluoroscopy time doesn't tell you that. It doesn't tell you if you were really well collimated or if the whole time you were fully opened. It doesn't tell you the geometry if you were doing everything laterally or obliquely versus anterior posterior, which we know anterior posterior is going to be your lower dose because technically we tend to be thinner that direct dimension, and etc. It just doesn't take into account all of these things. So why would you collect it? Do it only if you must, especially for the older equipment. All right, so we just talked about all of the various different metrics common to fluoroscopy systems. Now, as I mentioned, some fluoroscopy systems can actually do a spin rotation and acquire a tomographic or 2D, 3D type data. The word just left me, the data volume, there we go. And so they have very specific metrics that we're going to explore now, because now we're talking about rotation and depth. We're talking about, a field of view or coverage that's large. And so we have to take into account a volume of data, a volume of patient anatomy that's exposed. So the common metric to use is the CTDI, the Computed Tomography Dose Index. Now, the Computed Tomography Dose Index was, as the name implies, made for CT scanners, traditional, not fluoro systems, but actual CT scanners you see in radiology. So I'm going to talk a little bit about the origins of CTDI, and we'll share, and then we'll obviously see why and where CTDI works and doesn't work for the spin fluoroscopy cone beam CTs. So to measure CTDI, you need some way to create scatter. So that is why we use CTDI phantoms. They are universally 15 centimeters thick, so they're not really thick. And they come in two different thick diameters. One is in 32 centimeters, and this is typically used to approximate the body. And the other in 16 centimeters, and this one is typically used to approximate the head. Some CT vendors many years ago used that to approximate the pediatric abdomen. We have largely moved away from that. All of your CT scanners, anything modern, more than 10, 15 years, the body, if you use a body protocol, chest, abdomen, pelvis, anything from the neck down, it's going to be using a 32 centimeter phantom to do your CTDI calculations, and anything basically from the chin on up is going to be 16 centimeters. We need the phantom because we stick the ion chamber in any one of these holes to make the error kerma measurements, but our bodies create a lot of scatter, as we talked about, backscatter for the skin, etc. But our bodies generate a lot of scatter as the radiation enters it. So we use these phantoms to try to mimic that same kind of environment, scatter environment. All right, so a couple of things to point out. When we're calculating CTDI, we're actually not calculating it dose to the phantom. It's actually dose to air. It's error kerma. We only use the phantom to create scatter, and it's at the center. Even though we'll make some measurements around the periphery, it's actually the dose to the center. So when you think of a CT scanner, the bore, you have isocenter right in the middle. CTDI value, that value that you see on your CT console, represents dose to the air in the center of the CT scanner if there was scatter from a patient body. And things to understand, these phantoms are made out of acrylic, so they are actually about 30-something% more dense than muscle. So obviously they're going to attenuate differently than our bodies. But like I said, from the beginning. CTDI is not meant to be A, a patient dose metric, and B, it's not dose to the phantom. It's just there to cause scatter. We typically will measure the value for CTDI, the air Kerma value at the center, using an ion chamber probe that is 100 millimeters long, or 10 centimeters. So we will put this in, we'll scan it, we'll integrate it. We're integrating over the length. We're summing the dose, or integrating over the length of the ion chamber. And the point of this is the phantom, as I said, creates scatter. So this blue line down here would be if there was a very, very, very narrow beam going in. And so there's very little scatter created. So you have very little scatter tails. In our more modern CT scanners, they're 64 slice, 4 centimeters, or even the new 16 centimeter, or 320 slice scanners. These have very long tails. And there's a couple of things. We want to collect this because we want the ion chamber to measure all of this. But as you can see, even these ion chambers can't collect all of the scatter for 2 reasons. One, they're only 100 millimeters long. And 2, the phantoms are only 15 centimeters or 150 millimeters wide. So if you have a 16 centimeter, 160 millimeter wide radiation beam from a CT scanner, this phantom is actually not even as big as the beam itself. So the fact that we use CTDI, these phantoms and all this for CT itself, it's difficult to make the measurement. Now think about that on a fluoro unit. We're not doing 4 centimeter imaging on fluoro. We have these 25 or 30 centimeter large, 40 centimeters, depends on the detector size you've got. And so one of these phantoms being 15 centimeters is not even nearly as good at collecting all of the scatter and doing an actual dose calculation for the dose to the area of a fluoroscopic spin. All right, so the next thing to consider is when we make our dose calculations to calculate CTDI, we're going to make some measurements at the center and along the periphery. And we do this so that we can take into account the area difference. So we know that the dose isn't perfectly homogeneous. It's a little less at the center, and it's a little higher at the periphery. Makes sense, right? Radiation is going to attenuate as it goes deeper into our body. So we do a little bit of math here to take into account the differences of the radiation area. So we multiply the center value by 1/3, and we add that to the periphery values, and we multiply that by 2/3. So this gives us a weighted CTDI value, CTDIW, which gives us a rough approximation of the dose to the area. Now, why does that not necessarily work once again? Well, when you consider the fact that these systems don't actually spin a full 360 degrees. They typically will spin a little bit more than 180 degrees, maybe 270 at most. But the point is if I have a CTDI phantom here with my center and my periphery holes, but the scanner is only maybe spinning under or over, there are certain locations here denoted by the alphabet, at least the English alphabet, A, B, C, D, E, no, A, B, C, D, only A, B, C, D. You can see that depending if it spins down or spins up, the values are different at those locations. So if you're constantly measuring at the center, those are pretty much the same. But if you're constantly measuring here, let's say at B, depending if you go up, spin up or spin under, those values are completely different. And so when you go to make your calculations, where you place the ion chamber will drastically change the dose that you measure when you're calculating CTDI on this machine. Now I mentioned that a single CTDI phantom is not wide enough. So obviously we could stack 2, 3, or 4 of these phantoms together, right? Well, the problem is our ion chamber probe is only 100 centimeters. It's not 400 or 500 centimeters, which is really kind of what we need. All right, so how do we get past all of this? I'm going to give you 3 options. You can pick your favorite. I will tell you what I do at the end, and no spoiler alert, it's the easier of the 3. So here we go. You can use the CTDI phantom as it is. It's a simple 15 centimeter phantom, so it's not super wide. Obviously, it's not going to be as big as you can't see the whole detector here, but you get the idea of, here's the X-ray tube. The X-ray tube itself is bigger than that. You place the ion chamber in it. There's a small difference though. Instead of using the 100 millimeter probe, we're actually going to use a small probe. It's called a farmer chamber. So we're actually doing a point dose calculation. And we're going to still place the probe in each of the locations. We're going to place it at the center, and we're going to weight and multiply that by 1/3. And then we're going to make our measurements on all the peripheries. And every one of those will sum up, and we'll once again multiply that by 2/3. So we're doing the same kind of calculation, but it's not really CTDI. So be careful calling it that. I know you can go find papers out there. You can go read some papers in the literature that will call this CTDI. It's not. So be careful what you call it. Some people, if you try to publish it and you call it CTDI, they won't let you publish it. So for what it's worth, you're mimicking the process of calculating CTDI. So how could we get a little bit better? Well, a group here in the US through the AAPM, which is the Society for the Medical Physicists here in the United States or America, we have a report 238, that's coming out, in which they looked at a variety of different phantoms. In fact, option 1, 2, and 3 all come from this report, as you can see here, report 238. In one case, they looked at using a very long phantom, 600 millimeter phantom. It actually comes in 3 chunks. The thing weighs, I'd say it's probably getting up close to 70, 80 pounds when you heft that thing around. So it's not for the faint of heart if you're lugging this thing around. It's got a center hole, and it's got a couple other holes, one at the periphery, and then there's a couple of holes, not at necessarily the periphery, but kind of intermediate. We're going to still use the same phantom, ion chamber, the pencil chamber, the farmer chamber, and that will allow us to make sample measurements along this entire length. Now here you go, you can see the detector is actually on the bottom. And so this detector, you can see, is obviously smaller now than the the phantom. So in this case, we'll actually be able to capture all of the scatter. So we're getting better now. The issue with all of this is, you can go buy this phantom. I did. It cost me here in the US, goodness, I think it cost me $8,000 to $10,000 US dollars. So you can go buy these and you can place them all over Thailand if you want. But the fact that they're about 80 pounds, they're not really easy to move around. Some people will go and they'll just have 4 or 5 CTDI phantoms because they already own them doing CT scans. So they'll just take those and just kind of tape them all together. You could do that too. But you got to understand it's going to take about 4 CTDI phantoms taped together to get the same equivalent length. Small difference is this is actually made out of polyethylene, not acrylic. So this material is tissue equivalent. It's actually soft tissue equivalent. So it will cause or create scatter more similar to our abdomen than the CTDI phantoms. All right, so all of that aside, how would we use this phantom if you were so adventurous? Well, the idea here is if you were to place your ion chamber at the center and you turned on this beam and you did your spin, and you collected all your radiation, well, you're going to get a bunch of scatter. And so we need to collect all of this scatter data. Now, once again, we don't have we don't have an ion chamber length that's 600 meters long. You just can't go buy one of those ion chambers that are 600 millimeters long. So the other thing we do is we use a really small one, and we take it and we place it at the center of the phantom, and we do a spin. And then we move it 5 centimeters, 10 centimeters farther towards the end of the phantom. So we're going to start here and we're going to increment our way towards the end of the phantom. And we stick it in the center, and then we spin, we move it 10 centimeters, spin, and we just keep going. So it's going to take a while because it takes you, 45 seconds to do a spin or something, 30 seconds to do a spin to get it all set up and to do it and whatnot. But every time we do it, we keep adding. We're accumulating the amount of radiation. It's the same as if we were making our measurement here. So I made a measurement here, made a measurement here. So we're just summing all of this data up. And as we keep summing it up, it keeps increasing, increasing, increasing. And it will continue to increase all the way to the end of this phantom until it gets to a point where basically it plateaus. And this value right here is called the equilibrium dose. This is the value, is the same value as if you had a 600 millimeter long chamber and you measured all of this all in one shot. So that's our way to approximate having a very, very long ion chamber. We just take a really small one and make a lot of small measurements as we keep summing it up as we pull it towards the end of the phantom. So just a couple of hints here. How do you know? You can't see through this phantom, so it's really hard to know that you got it in the center. So obviously you'd push it to the center, you turn on your fluoro unit, you turn it onto fluoro mode and actually see that it's centered. And if you take on you see the cable that comes out. Well, what I do is I actually physically take the cable and I put little markers on it every 5 centimeters or 10 centimeters. And so I know when I pull it, go from one mark on it to the next mark, I know I'm pulling it 5 to 10 centimeters out. So I can center it using fluoro. And then once that's on, I can't keep turning fluoro on to position it because then it would ruin my measurements. So I center it with fluoro and I go back and now I'm doing my spin modes and I know exactly how much to pull it out every time. Small little hint. All right. I'm not going to beat you up with all this math. If you really, really want to, you can go AAPM report 111 will tell you how to use this dose equivalent value. Once you make all of these measurements, as you can see here in this plot, and this curve, if you fit this curve, it's a rise to equilibrium curve, this H of L curve. If you take this curve at the measure of the center and the periphery and all these locations, and we know what the equivalent dose, the dose equilibrium point is. In this case, for the center, it's 40 milligray. Here for the periphery, it's 50 milligray. So we know what those values are. If you take all those values, you can do all of this math. Here you can see that they're kind of doing a weighting equivalent to CTDI W. Here you see the 1/3 and 2/3, 1/3 and 2/3. So like I said, I'm not going to go into the detail of the math. I think that's beyond the point of this discussion. But you can do that. So why are we doing all of this? I think the most important thing for you to do is if you did this, you would make this measurement all the way out here. You'd get your equilibrium dose value. Well, if you take the ratio of equilibrium dose at the center and the ratio of the equilibrium dose at the edge, that value is approximately 100% of the dose to the area of the phantom. So if you use just a simple CTDI phantom that's 15 centimeters thick or wide, and then you have either the 32 centimeter diameter or the 16 centimeter diameter, you can see that those only approximate roughly 50% to 87 to 90% of the actual dose being delivered in the area of the cone beam CT. So they highly underestimate the amount of dose coming out of your system into this area that it's imaging. But if you know what your equilibrium dose is at the center and at the periphery, you know what the total dose is to that area. So that's the reason why we're doing all this. What you typically will do is you'll do that. You'll go to all this trouble with the phantom once. And then once you take that phantom off, you'll place the ion chamber in air in between the two, and you'll do the same spin, and you'll take the ratio of those in air measurement versus the equilibrium dose measurement. And now you have a correction factor. So the next time you come, when you have to do these measurements next year, you don't need to lug that big 70, 67 pound phantom everywhere. You don't have to set it up. You don't have to sit and pull it out as you keep doing 10, 20 spins. Take you hours to make those measurements. I promise you it takes a long time. But just to simply set it up and do an in-air measurement, boom, you're done. Takes you maybe 10 minutes to do that measurement. So that's one way to make option 2 more reasonable every year after. All right, option 3, and this is the easy option I was kind of referring to. What you do now is you set up, you got your ion chamber here, some kind of stand. Here's another wonderful use for all those plastic blocks. You just use it to extend your ion chamber off into air. You can see here how it's set at a lateral position. So when you do your spin, it's off the table. So there is no table in any way attenuating the beam. You're going to place some kind of filter. You either place it on the X-ray tube side or you put it on the detector side. Where you put it is very, very important. You have to be consistent every time. Because if you put it on the X-ray tube side, when the photons come out, it reduces the beam, so the value you measure on the ion chamber is going to be low. If you put the copper filters on the detector side, then the photons will not attenuate, so the value will be high at your ion chamber, but then they will be low at the detector. It doesn't matter. You're using that copper to make the system think there's a human being on that table. 3 millimeters of copper is a roughly good way to approximate the abdominal thickness of an average human. So we set it up, we make our measurements in air. Wherever you put your filters, you are consistent year to year. Done. It's actually a much simpler way to do it. So a couple of things to take home as we wrap up the second part of this is the cone beam dosimetry. It is not straightforward. It is not nearly as straightforward as was what we talked about with fluoroscopy. It's just because it hasn't quite been developed yet. It's being worked on, but that means there's not one way to do it. There's actually multiple ways to do it. 3 ways right now that are being proposed. How you do it is your choice, but you need to be consistent however you do it over time. And I would say if you're trying to compare one hospital to the next, you need to make sure the values you're collecting are the same across all of Thailand. So you have to just make that decision as a committee. All right, so up to this point, we've been talking about dose metrics that are values that you will see on the monitor in the room when you're doing your procedure. And those are values that you'll collect for your diagnostic reference levels. You'll collect for your alert levels. You'll collect just for your statistics. They do not necessarily relate to the human being, the body. Now, we can make calculations to calculate the peak skin dose or the entrance skin dose. We demonstrated that today. But that still doesn't really take into account how much radiation dose the patient is receiving. There's really only one way to do that, and that's either to make actually 2 ways. Physical measurements, if you have one of these anthropomorphic type phantoms, which here you can see I was doing this about a month ago. This is an adult male size phantom. That guy weighs about 140 pounds. So, well, no, he's about 70 kilos. So he's about 70 kilos. So he's not easy to lug around. And I've gone through, and you can see I actually put one breast attachment on it. So he simulates both my male and female. And I place these MOSFETs. They're called MOSFETs. They're small little dosimeters. The dosimeter itself is about 1/4 of the size of your pinky nail. So they're really, really teeny. And so I can place them all throughout the volume of the phantoms I use. Here you can see an example of an adult male. We did a bunch of measurements in the lung, basically in the chest region, the mediastinum, and then in the abdomen of a 5-year-old phantom. So they're just placed all over. The nice part about this is I can do a bunch of measurements in these phantoms, so I can get organ doses, and that really gives me a better understanding of how much radiation a patient, if they were of this same size, how much they would receive. And so it gives me a better idea of risk and patient dose. It's not true patient dose. The other option would be to use really high-end software called Monte Carlo, where you would take the actual patient images and do a lot of calculations on it, and it could tell you what the organ doses are. So there is no real one way to calculate patient dose in fluoroscopy. Just like we talked about in CT a couple weeks ago, there really isn't a way to do patient dose in CT either. A lot of great ways to approximate it, do a lot of calculations. So we're still getting there. Hopefully in the next decade, we'll make it a realistic approach that every time we're imaging someone, we'll actually know what their dose is, but we're not quite there yet. All right, so let's take another step back. So we've been talking dose metrics. We just talked a little bit about patient dose. Now, what are the effects that we're considering? Like I said, skin is our number one organ, it's our critical organ, the one that we're most concerned about. We know that tissue effects have a threshold. Any dose to the skin under this limit has no effect. That is well established. So what are the values? Well, the approximate values for early erythema and epilation. So you start to get a little bit of reddening on the skin. You lose maybe a little bit of your hair. That's roughly in the 2,000 to 3,000 milligray. So 2 to 3 gray levels. And the effects themselves can take upwards of 3 weeks to manifest. So typically what's going to happen is if you're in there, you're going at the end of the procedure, you see the cumulative air kerma dose is somewhere in the ballpark of 3,000-4,000 milligray. You're going to say, hey, I think there may be a skin effect. You'll ask your physicist to do some calculations. They'll do all those corrections to make sure it's actually dosed to the skin. And then they'll realize, and then they'll come back and say, yeah, this patient got, let's say they got 3,300 milligray. In that case, you'd probably say, well, let's bring the patient back in 3 weeks and we'll do a quick inspection to see if there is any effects. Obviously, as the dose gets higher, the effects get more severe. And then the onset times do tend to get a little farther out. And that's just because now we're talking about dermal necrosis. We're talking about deeper effects. And it takes a while from those deeper tissue effects to manifest all the way to the surface of our body. So one thing that is important to understand that we're starting to better understand now is the radiobiology effect in fluoroscopy. The reality is we're not therapy. We're not delivering 1 gray of radiation every minute. That's nearly instantaneously giving a high level of radiation all at once. This is meant to kill tissue. It's meant to kill cells. And obviously, it's because it's being focused in on tumors, right? So that's the whole industry around radiation oncology. The reality is for us as interventionalists, we're maybe on a high-end case, a complex case with a large patient, maybe we're doing 1 gray per hour for a procedure. And so this dose, be it high, 1 gray, it's high, it's averaged over the entire exam. So 1, 2, 3 hours, depending on how complex the case is. And so throughout this high dose procedure that may take a couple of hours, tissue repair is actually happening. Tissue repair can't happen instantaneously. That's why we kill tissue when we dump that much radiation all at once. But if we're giving a little bit now, 10 minutes later, we give a little, or a couple minutes later, we give a little more, and it just accumulates over 2 or 3 or 4 hours, that's okay, because as we've been going along, some of the effects from the beginning of the procedure have actually already started to correct themselves by the end of the procedure. This is what we call the dose rate effect. The idea that the thing that's being damaged, the thing that we have to worry the most about that is being damaged by radiation is DNA, right? We know that. And more specifically, we're worried about the chromosomal aberrations from DNA, from radiation effects to DNA. And even more specifically, we're worried about double strand breaks. The double strand breaks are the more lethal type of DNA damage. Single strand breaks, which happen all the time, just from breathing, from the aerobic and anaerobic process that happens in our body, from the Krebs cycle, from metabolism, all of those things. We have a lot of single strand breaks happen all the time. So it doesn't even take radiation to cause this kind of damage. But what's happening here is double strand breaks can be repaired if you give them enough time in between insults, in between points of time where they're hit with radiation. And so the reality is the procedure that you just performed, they may have a cumulative air kerma value of, say, 3,000 milligray. And your physicist goes in and does the calculation, and they say, yeah, let's say it's 3,100 actual peak skin dose. But then you bring the patient back 3 weeks later, there's no reddening, there's no skin loss, and you think to yourself, well, I thought 2 to 3 milligray. I got this plot right here. I got this table right here that says I should have transient erythema in that time frame. The reality is, because of that dose rate effect, the tissue actually didn't get a peak value of whatever. It got a peak level of that, but the effect did not cause the same equivalent damage to the tissue as if you had given all of that 3,000 milligray all at once. And so that's why I think more and more now in the interventional world, most centers don't really worry about doing skin dose calculations until it's about 4 or 5 or 5,000 milligray. And that's because we just don't see these effects at the low levels. That's something for you to consider at your own hospital, what level you consider is critical to do your dose calculations and to bring your patients back. But like I said, anecdotally, I can only say that, anecdotally, I see most centers here in the US moving towards 5 gray. Now, that's tissue effects. It's an interesting thing to also consider the stochastic effects. So if our patients are going in for these complex procedures, and let's say it's a cath procedure. So this is something that they may have to come back 2 or 3 times doing embolisms. Maybe you're doing some kind of, I don't know, you're trying to do some valve replacements, or they need to come in every couple of years to get something done with their pacemaker. So let's just assume these are very intense. These are high dose procedures, and they're happening over the course of 2-3 years. Well, if you give that same amount of dose, that's the equivalent of 1, 2, or 3 years all at once, we know that there is a linear effect. And there's an increased chance of stochastic effect, or increased chance of risk of cancer. This is a publication. They were just looking at lung cancer. So irrespective of what's here on the y-axis, if you give the dose instantaneously all at once, small or even really high, your risk of stochastic does go up. But look at this. This dashed line down here is what we would probably see in the interventional world, where now you got one complex case, I don't know, a year, 2.5 years ago. And then they had a follow-up 3 months later, and a follow-up 6 months later, and a follow-up at a year mark, and then a follow-up at 2.5 years. So they've gone and they've had these complex, higher, quote unquote, dose procedures, but it's spaced out over the same 3 year. You can see that their risk is almost nil. It's almost no different than it would be from background, which is considered at 1. So this dose rate effect not only affects tissue effects, that's why we're not seeing as much skin erythema and epilation, and it's also why we don't have a epidemic of cancer patients coming out of our cath lab or our interventional lab. It's because it's just this beautiful effect from the dose rate. So radiobiology is pretty amazing. When you actually start to put the biology and the physics together, you get some really neat outcomes. All right, last couple slides summary, and then we'll move on. Wow, I've been long-winded. I've gone a little long today for this first session. So summary, dose metrics for fluoroscopy. We looked at CAP, which best relates to the overall risk or cancer, stochastic risk. So if there was a metric that related to cancer or the risk of cancer, that would be your CAP. Of course, you need to have a conversion factor to get that from CAP to something that we understand, such as effective dose. Cumulative air kerma at the reference point is the value that's the most important when it comes into considering tissue effects, such as our skin. And we can use that to calculate the actual peak skin dose. Fluoro time, only use it if you absolutely have to. Dose metrics for cone beam CT there's no consensus. There's really no straightforward way. I highly recommend you just use the easiest method out there for now, which is the in-air method. You don't need to beat yourself up hefting those big phantoms all over the place. All right. My apologies. I went way over on our 1 hour talk. So I'll turn the time over to Tanya for
Thank you
question and
so
answer.
much. Yeah, it's always excellent to listen to your lectures, and thank you so much for simplify that formulas and make us understand like a step by step how can we get those number and get the final number like an accurate number. So my question to you is, when we look on the screen or like for the air curve compared to the accurate number on the formula, so at least can we say that the number that we see the screen is maybe like a plus or minus 20% of the accurate, like the actual number? So at least give us some idea.
It's hard to say because for me, I am about 170 centimeters tall.
Mm-hmm.
If which worst case scenario, you have 100 centimeter tall, you're really short physician. That dose, that number on the screen will be so different between me and the other physician. It really has a lot to do with the height, at least in an interventional procedure, in an interventional room. It really depends on where that table is, where the patient is. So yes, in a normal situation where the table is basically at the same level of the interventional reference point. So we're talking about 90-ish centimeters off the floor, about a meter off the floor. Then yes, I would say you're probably within 20%. So let's assume your table is about a meter off the floor. And if you look up at if you look up at your screen as a good physician, you're just kind of watching your fluoro dose. And you go, okay, 500 milligray, 1,000 milligray, 1,500 milligray. You could just assume it the worst case scenario. Maybe it's a little high. So you could say, oh, okay, it's not really 15, or it's not really 1,000 milligray. It's maybe, 200 or 300 milligray higher than the number you see. Does that change what you as a physician will do? Probably not. I mean, you have a procedure, you have a sick patient on the table. You're going to see the patient through to the end. Now, one of the things we do talk about all the time as physicists when we work with our physician colleagues is we ask them to kind of stop. We ask you to stop. Let's say you hit 2,000 milligray, you should pause and ask yourself, okay, we've come this far in the procedure. What more should we do? Is there anything we can do to reduce the overall risk going forward? Maybe can we adjust the angle? Can we move the skin port, come at it from a different angle? Now, maybe you can't. Maybe you are stuck in that location. Okay, that's fine. We keep going because you have to do what you're doing for the patient. And so maybe you hit now 4,000 milligray. We would usually ask you to pause. Okay, how far we've come this far? How is the procedure going? Are we making good progress? How much longer do we think we need to go? And we just take these road markers, and we just ask the physicians to kind of stop and think. Is there anything they can do every couple of, 1,000 milligray, maybe every 30 to 45 minutes in the procedure? What can they do to reduce the dose? Now, once again, this is all interventional stuff. If you're in radiology and you're doing a VCUG or a video swallow, we're not talking about these dose levels. We still want to keep the dose low. We want to be reasonable, but we do not have to worry about skin doses in those cases. And we're going to talk in the next session, we're going to talk about what we should do for alert values. So how to be good stewards of radiation dose, even when the doses are so low.
Okay, that's good to be. So which means like let's say the number, the height of the physician, maybe 160 to get like that 20% plus or minus, right? 160 or 170 centimeter height, maybe. Yeah. So which means like the average for Thai people.
Yeah, it's funny because in the last hospital I worked at, we had two principal interventionalists. It was a children's hospital, so we only had really two main interventionalists. And one of them was a really short guy, really short guy.
Okay.
And so whenever he had a procedure that was very complex, I always knew I had to do a dose calculation because the table was so low, it was really close to the X-ray tube. And I mean, that's just unless he stood on a stool, which a physician's not going to go stand on a stool.
Uh-huh.
It was just something we had to deal with. That's fine. We work with that. And he knew it. He knew he was short compared to his colleagues. And so but he was really good. He was really, I mean, he was older. He had been there doing this for 40 years. So he was very efficient at getting in, doing the job, and getting out. But it's part of the process. You have to deal with the geometry of the system and the operator, if you have tall operators or short operators.
Sure. I think we have a questions from the audience on the Zoom, and I just unmute her.
Okay, wonderful.
Yeah, คุณเพชรจากจุฬาป่ะคะค่ะ
ครับ
Okay.
She
No
muted
problem.
herself.
Okay. So I have another question, Sam. I see that you mentioned about the tube, like a over table and under table for the tube. Can you tell me or discuss about like a pro and cons? Which one give like a more radiation dose, less radiation dose, scatter radiation, or like a pro and con on each of them?
You know, they're both great systems. It's funny, if you talk to the vendors, the only reason they build under table X-ray tube fluoro systems anymore is because of the United States. For whatever reason, physicians here in the US prefer the tube under and the detector on the above. But if you go out into Europe, I could be wrong, but I bet if I went into Thailand, I would probably see a lot more over the tube above the patient than below. Those types of systems tend to be used more internationally. Now, why is that? Those systems, because the table, here I can, where is the picture of the guy? There it is. All right, hopefully you can see my screen back. So
Yes.
the nice thing about these systems right here is that tube can go really high. You can actually do radiographic imaging, normal DR, CR type imaging on these machines. So a big reason why these machines are used everywhere, mostly outside of the US, is because they're multi-purpose. You can do both fluoro, and then if you pull the tube up, you could actually do abdomen imaging or short field chest imaging. You can do long bone imaging for the legs and stuff because the system will move. So they're actually very versatile. You can actually do scolies on these machines. You can tilt the machine up, get the patient vertical, and the tube will just drop and you get a nice scolie shot. Whereas you can't do that with these. This X-ray, the detector here, either an II or a flat panel, it's too close to the patient to do normal diagnostic work. That machine, the under table tube machine, can only be used for fluoroscopy. But now, is the fluoro dose greater for this than this? They're about the same. For fluoro doses, the one difference when you got the tube up here versus the tube below is you, the operator, get more radiation dose. With the tube down here, a lot of that radiation, as we talked about last week, most of the radiation that scatters off of the patient scatters back towards the tube. So if the tube is below the table, it's your legs get more radiation dose, but your legs are not that radiosensitive. Now, if you're over here, so now the patient is on the table and the X-ray tube is up here, now the radiation is bouncing off the patient and going up and out. And so now your upper body, your face, if you're standing, if you're operating on an angle, maybe the side of you, as an operator, you get more radiation. So some systems, like this over tube table, they're called remote systems, where the actual operator is in a booth and they're not even in the room. For us in pediatrics, especially in pediatrics, we don't do that because you're a radiologist. You have to be in there almost always touching the patient, moving the patient. And so for these types of systems, you as an operator would want to make sure you have all your protective gear on because you get a lot more radiation. But that's really the biggest difference.
I see. Okay, that makes sense to me. Thank you. So two
Yeah.
more questions, Sam. Two more questions on the chat box. So the first one is, should we do the report when we found the CAK higher than 5,000 milligram?
I would say yes. At my institution, that's my threshold. So if the cumulative error curve is 5,000, then I, the physicist, will do the dose calculation. Now, we had a patient just a couple of months ago. It was a cath procedure. So they had biplane. One was over 5,000, one was 4,500. And we did the calculation for both. And you would expect at 5,000 and 4,500, you would expect to have some kind of tissue effect, some reddening, maybe some hair loss. Nothing. Nothing. So we talk about that dose rate effect helping save our skin from having all of these effects. I still will do my calculations at 5,000 just because I want to be safe. And we file the report and we put it in their patient records just to so, and this is, I think, the most important part, so that let's say they come back 3 months from now and they have the same procedure. Well, the physicians will be able to go in and say, oh, 3 months ago, they just got 5,000 from this side, 4,500 from this side. Now, if we do it all again, the fact of the matter is over time, the risk may not change as much, but the skin isn't going to be as resilient to radiation. So if I give it another 5,000, another 4,500, I might actually see an effect this time. And if they come back another 3 or 4 months from now and do it all again, you may eventually see the cumulative skin effect over time, where the second or third procedure, you start to get ulcerations, you might start to get lots of hair loss. And so I do my dose calculations so we have a record of it. And so the physicians can plan, oh, maybe we don't come at it perpendicular, maybe we come at it from a different angle.
I see. That makes sense. Yeah. Next question is about you gave us 3 options on the measurement, right? And for the third option, using the air method, can we use the 100 millimeter ion chamber for this test? Would you prefer to? Yeah, prefer to test? On the detector or tube side?
Sure. So let me answer that. The answer is, if you do choose to use the 100 millimeter chamber in air, that's fine, as long as your field of view is less than 100 millimeters. So the beam that's coming out of the X-ray tube at the center, so you're basically putting here, let me pull this down. And right there. So let me look at a little bigger. This chamber right here, this is actually the small one. We call it a pharma chamber. And because it's small, it really doesn't matter if my field of view is big or small. It just doesn't matter. So that's why I use a smaller chamber, a 15 cc, maybe you could even do smaller if you want. Not a 15, excuse me, a 0.15, 0.15 cc or 0.3 cc. It's a small volume. Now, like I said, if you use the 100 centimeter one, you just field of view is make sure it's smaller, or it's so that you can, because there's no scatter in air. So you don't have to worry about the scatter tells. You just have to make sure all of the radiation beam on a 100 centimeter one is within that field of view. Now, we know that it's not, that the small one, we know that the field of view is not smaller than the tiny field. And so that's okay. That we know that is only a sample of the overall dose. As long as you're consistent, use the same ion chamber, use the same collimation, use the same location every time. I put my filters on the detector. So like I said, if you put the detectors, the filters on the X-ray side, on the source side, you reduce the amount of radiation by the time it gets to your ion chamber. The second thing that happens is you actually do create scatter coming off the copper. You will get scatter coming off this. So you have the potential to change the measurement every time, because scatter is going to be different every time you make a measurement. Whereas if you put the filters on the detector side, well, the detectors are still going to cause the system to change, the automatic exposure rate controls. It's still going to make the system use the same output every time, but the dose that you measure on the ion chamber will be consistent. I personally believe it's more consistent that way. So use whichever probe you want. Make sure the field of view, if you use the 100 centimeters, is smaller than that the chamber. And then I personally put the filter on the detector.
And last questions. So should we pay attention to the eye lens dose for the neurointerventionist, and how much for the CAK or PSD level will represent the harm to the arm lens for this kind of event?
So the answer is yes, we definitely should. It's gone from 150 down to 50, and in Europe now, I believe it's even 20 milligray. So they keep reducing what they consider is a safe amount of radiation to the eye lens. And this is just because we're seeing more incidents of cataracts. That's what we're dealing with, is opacifications. So how can you be safe? If you are at the table side, if you're a physician, I would recommend wearing glasses, leaded goggles. So you get the wraparound glasses. You don't have to get the big bulky goggles, and you can if you want. They have nice ergonometric glasses now. That's good. But make sure they wrap, because, I got my reading glasses on right now. And if I turn my head sideways, my glass doesn't wrap around. So if you're consistently looking at the monitor, but you're stepping on the pedal and the patient's right here, you'll actually get radiation shine through to your eye. And so you need to make sure your goggles or your glasses wrap. They are really good. The lead in your glasses are as good as what you get in your thyroid shield and your chest, in your overall lead apron. It's not as thick because it would really kind of hurt your nose after a while, but they're still really good. And so yes, I would do that. And like I said, the numbers keep changing. Here in America, in the US, we've gone from 150 down to 50. We haven't gone as low as Europe. Europe is really low now. They're at 20. So I don't quite know which one Thailand subscribes to, but I would just err on the side of safety and wear leaded glasses, especially if you're at the table. Now, there are people like anesthesiologists that'll be in the room. So in pediatrics, we knock a lot of our kids out for interventional procedures, all of them. So the anesthesiologist can sit off on the side of the room, and usually we'll have a rolling cart, like a leaded shield. And so they do not have to wear glasses. Nurses that are coming in and going out, technologists even, they might be operating the machine, but they'll be at the end, the foot of the table. They might not even need it because there's not a lot of scatter at that point. Every step you take back, so basically every, not meter, but a third, a half a meter or so, about every step you take back from the table, the dose drops, the scatter dose drops by a thousandth. So every point away from the table, your scatter exposure goes down really, really quick. So unless you're the doctor, the physician, really kind of at the patient side, or a supporting nurse or technologist right there next to him, I wouldn't worry too much about glasses.
I see. Yeah. So come back again, Sam. Last questions about the third option. So do we place the dosimeter in the distant half, the SID?
I would put that dosimeter right there. I would put that at your IRP. So if you're in the interventional room, you're going to place it right here at the IRP, because that international reference point is the value you see on the monitor. And so that's just, so you're still doing your spin, and that value will then, it's not perfectly at isocenter, so just point that out. But that's the point that you'll see in the report. So when you get the report right here, well, we didn't do any rotations on this. There will be an error Kerma value for the rotation. Oh, actually, I do have, where's my cap? There you go, this guy right here. So you can see here, this roll, this cone beam CT, it had a cap or DAP of 6.07, and it had an error Kerma value of 18. So that 18 value was measured at this point right here. Now, if you want to make it just super simple, you could put it at isocenter. But like I said, just be consistent. Because like I said, this value is a value you're comparing every year. You just want to make sure that machine is the same year to year to year to year. And if you do the same measurement on machine A and then machine B in the next room, that's a good way to make sure your rooms are giving you about the same radiation dose, going from room A, room B, room C, all the way down the hallway. So whatever you do, just be very consistent, and that should help you compare all of your values.
I see. Wow, we have a very productive discussion today. So come back again, Sam, for the lendos. So last question, we talk about the physicians lendos that we need to wear, like the goggle to protect the eyes, the lens. And how about the patient?
Should we worry about the...
So the for the patient.
Yeah, so if you're doing a neuro case, the question is, can you do the procedure as a physician? Can you do what you need to do without the beam right on their eyes? If the answer is yes, then yes, do that. But if you as a physician absolutely need to put the beam in, maybe you're coming in from the back side of the head and it's coming out the front of the head, as a physician, you have to make that decision because you are there to help them. And so you can't worry about effects later in life. Because if they die because of an embolism, if they die because of something going on at that moment, what does it mean if they would have got a cataract 5, 10, 15 years from now? Now, if this is something that you can do, maybe you can go in laterally to do it. If you come in from the back, obviously the beam will attenuate by the time it gets to the eye. So even though the entrance dose back here is a little high, the dose coming out at the eye is much lower. So probably the only thing I would not recommend as much as you can do is put the radiation beam going into the eye, straight into it. But most of the time your tube is underneath the patient. Because if the tube is above the patient, well, guess what? The tube is next to your head as it is the physician. And that means all that radiation's bouncing back at your face too. So it's not the most ideal place to put your X-ray tube. So as much as possible, sure. Let's try to do that. And this is why in CT, when we're doing CT of the head, that's is why we typically tilt the gantry so that, if the eye is here, if we're going from the SOM, if we're going to the medial down to the ridge of the eye, down to the medial, forgive me, I can't remember it, the medial something, the hole in our ear. If you thank you. If you match that line right there, you're mostly keeping the primary beam off of the eye. You still get scatter and you still get some dose to the eye, but you're doing your best to limit it. And have we seen people have there been studies that have shown cataracts that have come from CT? And the answer is, to my knowledge, no. And the same, I think, was with interventional procedure. I do not think we've ever seen, there's all these patients that are getting this type of, say, embolism or some type of procedure. They all have cataracts 10 years later. I don't think there's a procedure. I don't think there's any study that has shown that.
Yeah. So the answer is there is no dose limit for the patient's lens because we need to treat the disease.
Yes. That's the simplest way to say it. You should have answered the question.
No, okay, sure. Thank you so much, Sam. So you can move to the next session. Then we are going to talk about the dose alert level. How can we set it up, and how can we do with those stuff when we see or we hear something like a beep, 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 beep? We just stop and continue, or what should we do?
All right, let's see. Okay, hopefully you see my screen.
Yes, I can see your screen.
Perfect. So we just talked about the metrics. Now let's put the picture together. What do we do to optimize our radiation output? So we talked about this, and I think I showed this slide last week. Fluoroscopy comes in all different geometries and shapes and sizes. There are some principles. There are principles that are consistent for all of these machines. But for the most part, one of the most important things that affects radiation output is how we use the machine. So keep that in the back of your mind as we go forward. The radiation dose to the patient and ultimately the exposure you get as a physician in the room or a technologist or physicist all depends on the way we use this machine. And then as a quick reminder, when we were optimizing imaging quality last week. Now we're going to try to optimize patient exposure. There are a lot of variables. There's probably something like 50 variables around this. And it's really hard because if you change something over here, it has a downstream effect that may change image quality over here. So we'll just kind of keep that in the back of our minds as we start talking about the things that we're going to try to do to optimize. All right, so first thing I said, the most important thing for dose optimization is determine how we use the machine. So the other techniques that influence patient dose are going to be total time. Obviously, if you want to reduce the amount of dose you give to the patient, reduce how much you're stepping on the pedal, how much time you're actually exposing them. The geometry, which we've talked about today, the pulse rate, which we talked about last week, and filtration. Excuse me. So let's talk about total time. This is a no-brainer, right? The less your foot is on the pedal, the less radiation the patient's getting. So what we're going to want to do is we're going to try to do intermittent exposures. We're going to want to use as much as possible the last image hold or the last fluoro hold so you can plan your next step. We're going to try to do as much of our imaging using pulse mode. Now, we did talk about the fact that there really isn't continuous mode anymore. Continuous mode of 20, 30 years ago is 30 pulses per second today. So it's actually the highest usually you go is 30 pulses. Some older systems can still go up to 60 pulses per second. Those were more typical in cardiac systems. But what we want when I say pulse mode is we're typically going to try to do as low a pulse mode as possible that gives you the image quality you need to do the temporal resolution to do what you need to do as a physician. All right, so geometry. We talked a lot about this idea of the isocenter and the international reference point, that being the point where we do all of our dose calculations. There's another point that's very important. You see this little X right here. So here's isocenter, and here's this point. It's called the compliance point, or if you're in the US, it's called the FDA point. It's 30 centimeters from the detector. It's always fixed 30 centimeters from the detector. And this is the point where the system is trying to match the dose. So if this point right here, this X, is aligned with our international reference point right here, well, then the dose, so if it's right here, then the dose that you see on the screen is going to represent the dose that's going into the patient, so the skin dose. Now, if you take and you move your imaging, your II or your flat panel, and you move it away from the patient, what you do is you've moved that compliance point, that dose point, up. Now, this point down here, the skin dose is getting more dose because the system is trying to make the radiation output to this point. And so you've shifted it from here. So let's say it was a good dose here. Now the dose is supposed to be quote unquote good right here. Therefore, everything below it is getting higher dose. This obviously only accounts for the fact that in some systems, mostly interventional systems, the II or the flat panel detector is variable. It can move up and down. And this up and down point can really drastically affect how much radiation is coming out of your system. In the United States, we have a point, 87 milligray. We have a dose threshold, 87.5 milligray per minute, or 10 R per minute. The systems, that is supposed to be its maximum output dose at that point that we were talking about, that dose compliance point. The dirty secret is that is true. I can go in and I can use all my blocks of plastic I've been talking about to mimic all my different sized patients. In fact, I can actually go put lead into my beam. So if I have my II or my flat panel right next to my patient where it's supposed to be, or my phantom, whatever I got here, and I put all everything I can possibly think of, lead and everything. So I make the system use all of the radiation it possibly can to penetrate all of my phantom. If this ion chamber, the II is at its proper location, the dose should not exceed my threshold. Now, if I move it up, it will exceed that threshold. You can see how it goes from 87 all the way up to 140 in this one particular machine. So what I'm trying to say here is on these variable II or flat panel systems, on these C-arms, you do want to keep the geometry where the detector is as close to the patient as possible. We talked about how that is the best image quality last week. In this environment right here, you'll have good contrast to noise ratio, less scatter, less noise. You'll also have less of a geometric blur due to the magnification effect. So this will give you the best resolution and contrast. That's great. It will also give the best dose to the patient, and it'll give the lowest dose to the operator because there's just less scatter coming off the patient into your face. If you have the II high, then obviously lower image quality, lower spatial resolution, higher dose to the patient, and potentially higher dose to you. Now, I recognize the fact that there are times where the detector has to be up a little bit because you may need to get your hands in there. I recognize that sometimes it just has to be where it has to be. But in the best case scenario, you should keep it as close to the patient as possible. Now, we talked a little bit about having the patient as far away from the X-ray tube as possible. This obviously depends a lot on how high you can use the table, how high you can set the table, and the operator can use it comfortably. If you have a short operator, the table is going to be lower, and therefore the patient is going to be closer to the X-ray tube. That's just something that you have to deal with. In a best case scenario, push it as far away as you can, and it just reduces the dose to the patient. In some situations, you can actually manipulate where the X-ray tube is. So on these tilt tables, one vendor that I know of, maybe other vendors can do this, but one vendor can actually, there's a button you can push on it, and it will make the X-ray tube go farther away. It goes from its normal position to down a little farther. If you do this, and this is how we use our machine at our center, because this is actually a picture at my hospital, it immediately reduces the dose of the patient by 15%, just because it extended the distance. Now, they built this here actually to make it a larger field of view. So if you had a big patient, the only reason they did that is so that you could actually image a little bit more anatomy. What they didn't realize was we would use it, as most people use it now, for dose reduction. So know your system is what I'm trying to say here. Know that. Make sure you understand all of the buttons on your machine. Make sure you understand all of the operating geometries, because there may be some geometries that are better than others, and you want to make those the defaults. And so ask your system vendor to make sure you're trained on all of the quote unquote bells and whistles, as we say here in the US. You want to minimize how the different angles where you're passing through a large portion of your body, the patient's body. So you want to minimize lateral projections and oblique projections when you have a rotating C-arm. The reason for this is obviously because if the machine sees there's more attenuation or more tissue between the tube and the detector, well, that means that the machine's going to have to turn up the radiation output. So therefore, the skin's going to get more dose. It's a simple. So we're thicker this way, it needs more radiation. We're the thinnest, typically anterior to posterior. So as we keep the beam more aligned along the thin geometry of our body, then we're just safer. It's safer for the patient. The next is, if you can, and we talked a little bit about this for peak skin dose, don't do everything in one skin port. If you can, move the patient. Maybe you shift the table a little bit superior inferior. Maybe you shift it laterally. Maybe you can actually move the x-ray beam. If you have a C-arm, you can actually move it. You can rotate it a little bit if you absolutely need to. But breaking it up, where, for example, you have a 30-minute procedure that gives you 1,500 milligray in one location, the same could be true 15 minutes, 10, and 5. And I know this is an exaggeration, but you move that patch around. Now there's no one max skin dose that's that high. So spreading it out. If you're doing angulations, make sure there are no points of overlap. So if you angle one direction and you think, oh, I'll save my patient some dose by angling a different direction, well, that's true for part of the body up here, but this point right here overlaps. And that dose hot spot, you may not think about that, can add up very quickly. So be very conscious if you are angling that you don't have these overlaps. Now, I have to admit this is not that easy, especially if the patient's draped in sterile cloth and so is the tubes. Some of the newer interventional systems, because they know the table location and they know the tube position, it will warn you if there is a hot spot, if there's an overlap. So as you're going along, you're seeing the dose map on the screen in real time. And if you angle, it'll immediately say, it'll warn you saying there is an overlap. You might be aware of it, or you may elect to move forward even though you know that there's an overlap. But at least some of the newest systems are becoming smarter and they're warning you. Okay, on these tilt tables, and to a lesser degree, some of the interventional systems, well, I guess I just say in general, these table pads, when we put table pads, we put patients on the pad, they're meant for comfort, right? But the pads absorb radiation. So if they absorb radiation, the system needs to put more radiation out to get the same dose to the detector. So if you have a tube up here and the detector down here, and you have a pad and a patient on here, if you put the pad here, this machine thinks this patient's thicker, so it will irradiate more. Okay, on this situation, this geometry, if you have a pad and a patient, the system still says, oh, hey, I need more radiation to get through, but the pad is between the patient and the x-ray tube, so the pad actually absorbs it. So in this geometry, if the tube is below the patient, you can use a pad. That's okay. It doesn't affect the patient dose. It actually helps it a little bit. If the tube is on the opposite side, so tube, patient, pad, then that will cause an increase in dose to the patient. And this is typically why in normal radiography, CRDR, we don't use table pads. They all climb on those horribly hard surfaces. The whole reason for that is because those hard surfaces do not attenuate that much radiation. And so putting pads and pillows and blankets and putting our patients on that actually increases the dose to our patient. So just be conscientious of where your tube is to your pad. Now, not all pads are created equally. There are some pads out there, and they tend to be the inexpensive, so the cheaper versions, things that you can buy from third-party vendors. They tend to be made of really attenuating material, lots of gel, lots of foam. And so these can actually attenuate the beam by 60%. I've seen them upwards of 60%. That means the machine has to put that much more radiation through your patient to create the same quality of image. So A, it can affect image quality, but B, depending on if it's an overtube, that can really increase the dose to your patient quickly. Usually the pads sold by the manufacturers tend to be the lowest attenuating pads available. It's just because they've been created or engineered for fluoroscopic procedures. The worst pads out there, and this is something we can't really control, but the worst pads out there are usually the comfort pads that are in the actual patient beds. So if you're doing a C-arm in maybe the ER, or if they're up on the floor and you took a portable C-arm in to do a procedure or whatever, and they're in just a standard hospital bed, those pads can actually attenuate quite a bit of radiation. And one of the things that, as a medical physicist, I like to do, for example, we've just added a small part to we added a building to our hospital. So we've increased the number of beds we have in our hospital. And the hospital went out and bought all these beds and all the new hospital beds and all these pads. And they, of course, they're looking at the most comfortable pads, the pads that hopefully reduce all of the bed sores and all of these things. They didn't think one little bit about radiation. And so when we found out what they bought, we did some measurements and I showed them that they've in effect increased the dose to all of our patients by 30 to 40% if we have to image using those pads. So just be careful of what pad you put, especially on the fluoro tables. You can control that in radiology. And work with your hospital counterparts as much as possible to help educate them so they make the correct decisions, especially in places like the ER where you do a lot of imaging. And it goes without saying, I know you all know this, but the dose that the patient gets, it directly affects the dose that you get in the room. Because as we know, the radiation goes into the body and it scatters off the body, and the radiation that goes into the body will scatter out of the body. And so the radiation that we are being exposed to, unless you're actually sticking your hand into the beam, the vast majority of the radiation we're exposed to in the room is from scatter. So if you're using a high dose, and therefore you're getting a lot more scatter out. If you're using a bad geometry, it's going to adversely affect the image and the patient, but it will also affect you. So just think of it as a 2-for-1. The better you are for lowering the dose of the patient, the better you are from reducing the dose to yourself as a staff member. Okay, so let's move on. So that's geometry. Let's talk pulse rates. So establishing the appropriate pulse rate in fluoroscopy is actually very important. It helps when we set up the procedures and the exam protocols from the beginning. It helps the physician when they walk into the room. They don't have to think, okay, this button does this button does this button. They can go in and they work, and their focus is on the patient. And if they're actually operating the machine like they typically do in radiology, then they know, oh, okay, I need a little more radiation. I just push the next button up, or I push the button above that. If you make it sensible, then it takes a lot of stress out of the process for the radiologist or the physician to operate the machine. So what we do is we need to set up anatomical programs. As the technologists know, when you load the patient on the system, well, what you're going to do now is you're going to tell the system what you're going to do. Is it a VCUG? Is it a video swallow? Is it a barium enema? Or if it's some kind of interventional type procedure, whatever it is, an embolism, whatever your procedure you've built, you have an anatomical program that you've established. And you need to set up some presets to it. You need to build into the background all the right values so that when you select it, it's correct for the right size patient. And so we need to make sure the pulse rates make sense for what we're doing in that, video swallow. We're going to have a higher pulse rate. If we're doing a line placement, a PICC line or something, we don't need a lot of pulse rate. We can do we can even do a pulse rates down to 3 pulses per second or 1 pulse per second. We need to set the system so it has the right kind of filtration. We talked about this last week, how all of the systems tend to want to use the highest filtration as possible. The higher the filtration, the lower the skin dose. That's the whole reason we use filtration in fluoroscopy. Well, 90% of the reason. The other 10% is to improve the image quality, to improve contrast. Too much filtration, however, can adversely affect contrast because your KV goes up. Higher KV means lower contrast in the body. And higher KV, higher filtration equals larger focal spots. That means your spatial resolution goes down. So there are trade-offs. If you're going to be imaging a little kid, maybe you're doing something in the heart, you don't want to use a lot of filtration because then you might not be able to have the resolution necessary to see the very small vasculature that you need to see. And then obviously you need to make sure that the system is set. So based on patient size, maybe the grid is already selected to be out versus grid in. We talked about the pros and cons of grids last week. Views, this basically means when you walk in, if you're going to be doing, say, a barium enema or whatever it is, you know that you're going to be doing maybe a fluoro, you're going to be doing maybe a couple of spot films. You have a procedure built, a workflow built. So you want to make sure that workflow is built and it makes sense so that when you're stepping through it, going from the next procedure to the next, you collect all the information. So when you get back to the reading room, you can do if you're doing it in person, you can do it so you can read through and do your diagnostic, get your diagnostic. Or if you're in the reading room, when the procedure hits your work list, you know that all of the imaging coming across will be able to provide the information you need to make your diagnosis. So how many fluoro units? Should you have digital images, cine runs, DSAs? You need to work all that out. So I talked a little bit about how you need to have the doses set as a function of size. So this is just an example of how we do it at my center. I'm not saying it's the right way or the wrong way, and you may differently do it a little bit different. Every system is going to have some way to adjust the machine so you can change the output to you can change the output of the machine. In this machine, it's a Philips unit. It has these 7 settings, and they just arbitrarily label them newborn all the way up to extra large. And so what we did in our anatomical programs is we went in, so let's say it's a VCUG, and we have these 7 settings built into our VCUG. And they're based off of these basic sizes, basic patient thicknesses, anterior, posterior, lateral, whatever you want to choose as your metric. And so we set it up so that the dose to the detector goes from small to large. You need to make sure you keep the right dose to the detector as the patient gets bigger and bigger. Remember, the dose of the detector determines the noise in the image. And it also allows the system to pick the right KV and the MA and the right filter for the procedure. So if you don't have the right dose to the detector, then all of these settings aren't going to be right. The image quality won't look right. The contrast will be a little off, and you may be even noisier as you get to bigger patients. So we talked quite a bit about, and I showed you some examples of setting the right dose if you go when you change your pulse rates. And you may recall it's called the Afrique principle and the Keith Strauss rule. So we talked all about that last week. I won't go over that. You can go back to those notes. But setting the right dose to the detector is actually very critical, and setting a variable amount, because not every one of your patients are going to come in looking a certain way, especially if you're at a pediatric center where you will see everything from neonates all the way up to obese teenagers. And then pre-program those so it just works seamlessly when you walk in. You, the physician, walk in to use the machine. So we talk about using pulse rates. Pulse rates, the number one way to reduce dose in fluoroscopy is just not push on the pedal, right? So reducing the total amount of exposure. The second one is using these pulse rates. So here is just a little bit of math that I did. If you have 30 pulses per second as your relative 100% dose level, so everything less than 30 pulses per second is going to reduce the dose. If you go down to 20, you've reduced it to 67%. Obviously, you go from 30 to 15, you've halved the dose to the patient. And then you go down from 8, 4, 2, 1. You see how the doses are dropping. If you're able to do a procedure using 1 pulse per second, you're using only 3% of the dose compared to if you had done the same procedure with 30 pulses per second. So obviously reducing it as much as feasible allows your system to reduce the dose of the patient. So it's just a quote unquote lower patient dose system. Now, what you want to do is set it up so that for every one of your anatomical protocols and all your procedures, VCUGs, video swallows, all that, you will set the appropriate pulse per second when the system is turned on or the exam is loaded. And you have to do this based on the clinical needs and obviously the comfort level of the radiologist. I can tell you in our center, we do all of our PICC lines and all of our line placements at 1 pulse per second. That's just how it's always been done. And it's been largely championed by one radiologist. He, of course, is the section head of our fluoro unit. Now, we've had other people come in and they've said to themselves and to us, 1 pulse per second it's too slow. Obviously, the image is 1 pulse per second. You're getting 1 image per second. So you have to adjust the way you think. You can't just go in and stick that tube and go right over into your patient, because obviously you're moving faster than 1 frame per second. And so it does take a paradigm shift on how you operate the machine. If you're willing to do that, and if you have the comfort level, then you can probably pick most pulses per second depending on the type of procedure you're using. This is simply an example. Once again, this is how we do it at my center. I'm not saying this is the right way. I'm not saying this is the wrong way. What you see here is just a general list. So as I mentioned, our tubes, GJ tubes, we set up our procedure to have 3 options. So you load the GJ tube procedure. On the console, there will be 3 dose buttons. And if you have a Philips unit, you know they're called fluoro flavors, as an example. Siemens has different, they're all just labeled something different. But in my case, we have 3 dose values. And the red values are the default values. So in the GJ tube, it's defaulted at 1 pulse per second. So if the patient the radiologist goes in there and they're trying to place this GJ tube and they're just running into a little bit of problems, maybe they'll choose to elect to go up to 2 pulses per second, or even maybe 4 pulses per second. So all they have to do is push the next button up or the next button up. Now they have no choice. They can't go up to 8 or 20 or 15 because that's just not an option in that protocol. So there is a limitation. Other vendors, such as I can speak for Siemens, for example, you can go from as low as 0.5 pulses per second all the way up to 30. And so you just have you would just open up a different window on your little table side system and push a couple buttons and boom, you got the world is your oyster on this one. You can do all the pulses you want. But in most places, you're going to set it up so you really basically have 3 options. And the why and how you choose those 3 options really just depends on working with the radiologist. We use for our video swallows, ours is 20 as our default. But if they really wanted to, for whatever reason, they could go to 15 and 10. And you see all the other examples. The reality is, though, is if you set the pulse rate low initially, and the radiologist or the operator walks in and they start working with the machine and they think to themselves, I just can't quite see or do what I want. Well, they obviously have the option to go up. And they, in our case, they have 2 more elevated dose options or pulse. But the opposite is rarely true. If you set the default at the highest value, you're rarely going to have an operator or a radiologist walk in and say, oh, this image quality is just way too horrible. It's too good. This is way too good, way too good. I want to reduce my dose. That rarely happens. So oftentimes we'll set it at the minimum, and then we give them 2 options or 3 options, whatever your system allows, to increase the pulse rate, or in other words, the dose to the patient. Now, when you do this, I have 2 examples down here. This is a machine that I worked with, and you can see that the 3 buttons on the machine would reasonably go from low, medium, high, which you see on the right graph. The irony is it actually went from low, high, medium. And every time I would go into service and work on this machine, I would adjust it. And then I'd go back the next year and it was all mixed up again. Every time the service engineer would come in to do their PMs or their routine periodic maintenance, they would take away all of my corrections that I put in it, and they would reload the software. They would basically refresh the system. It drove me nuts because every year I'd go in, I would tell my radiologist, if you want to go higher dose, go 1, 2, 3. And they would go in And they would do that 1, 2, 3. Well, guess what? They always stopped at 2. They never needed to go to 3 because guess what? 2 was always the highest dose. So you want to make sure your settings, whatever you set, are logical so that the operator just knows what to expect as they're progressing low to high. So I mentioned filtration so we listed filtration as another optimization. And I've already kind of talked about this, but filtration almost always starts as the highest as it works down as you get towards bigger patients. It's pretty much always 0.1 to 0.9 millimeters copper in all of the various different systems out there. I already told you that too high high filtration can reduce KV, can reduce low spatial resolution. Excuse me. So you want to optimize this as much as possible. All right. Now let's talk a little bit about cone beam CT. So up to this point, we've really just largely talked about fluoroscopic systems. I would argue those 4 principles are pretty much the same if it's an interventional system, if it's a tilt table, if it's a cone beam, like a fixed C-arm, like a mobile unit. Now let's talk cone beam. So I did a study end of last year, and I compared radiation doses from the cone beam CT, the spin that you can do in the fluoro system, a C-arm, compared to an actual CT scanner where you normally do your biopsies. So you can see my friend here, this phantom. It's got all my little MOSFETs in it. It's a male phantom with a breast attachment on it, so it mimics both genders. And what I did is I looked at a couple of different protocols or procedures. And we looked at doing biopsies. We looked at doing various different, we looked at a variety of different reasons why we would do a cone beam CT of the thorax and the abdomen. And we did it for an adult phantom, as I've just showed in the previous slide, and we also did it for a 5-year-old, just to kind of give us a range of the doses, small patient to a large patient. And I took these MOSFETs and I stuck them in all these organs. In the thorax, I did lung, breast, heart, and in the bone, I put it in the T-spine and the sternum. And from the bone, I got bone doses and red bone marrow. And then in the abdomen, I did just your major solid organs: liver, stomach, pancreas, spleen, gallbladder, kidneys, intestines, colon. And then once again for bone, I did the T-spine so I could get bone marrow. And what I did is I went in, what you did under fluoro, if you're in the C-arm, or if the CT system, you did a planning radiography or a scout. And I imaged the patient using 4 field of views. Max field of view, which is roughly 20 centimeters on my system, 12.5, 7.5, 2.5. And you can see I kept most of the MOSFETs kind of in that same image, but there are a lot of MOSFETs above and below that as I collimated down, down, and down, fewer of those of the MOSFETs are being exposed. So in theory, I was exposing less of the organs. And so the radiation dose should technically go down at each one of those. And I took those 4 field of views, those 4 different collimations, and I plotted the doses and I fit the values. I did a regression curve and a couple of things to point out. So I'll explain why I did the regression curves in a second. But first thing you can see here on the IR, so this is the C-arm doing the CT or the cone beam CT, the 5-year-old abdomen chest and the adult chest basically were all of the same dose. But the abdomen, when you're doing the adult abdomen, the dose is much higher. It was an order of magnitude, almost 2 orders of magnitude higher. Not order of magnitude, a factor of 2. You know, we went from 1 to a half to 2, give or take, 1 to almost 4. So a factor of 2, actually, I should say. And when you compare that to the actual CT itself, so doing just a normal helical CT of the chest or the abdomen, you can see that they were mostly the same, but a little bit lower than the cone beam CT from the C-arm. So cone beam CT, for all intents and purposes, used to be higher dose, much higher dose, several years ago than taking the patient down to a normal CT and doing your biopsies there. That's mostly changed, at least on the system that I have that we tested. And I think it's true for most systems as we've looked at this. In other words, if you're still upstairs in the, or wherever you're at in the interventional suite and you do a normal cone beam CT, obviously the image quality is going to be slightly different. We talked about that last week, but dose-wise, they're pretty equivalent. There are some cases where they may be a little higher, but they're mostly equivalent. Where they are different is the fluoro mode. So if you're on a interventional C-arm and you just step on the pedal and you're doing normal fluoroscopy, here you can see I fixed my ordinate axis, so they're the same. You can see that the fluoro dose is just nothing. It's right there on the 0 mark. It's actually higher than 0, don't get me wrong, but it's less than 10. It's less than 5. It's actually, I think, only 1. Whereas if you compare the dose in fluoro for CT biopsy, it's much, much higher. And that's just because obviously in fluoro, you're doing low real time, it's stationary, but in CT you're taking and you're making about 1,000 or so images, even though it's a relatively low MA, so you can create a volume image. So what we did is I created these regression models and I combined them together so that I could create one empirical model. And what this allows me to do now is I can go in and I can pick however many cone beam spins that I'll do on my C-arm fluoro, which is shown here in orange. So let's say for a 5-year-old, I go in and I do 4, and whatever procedure I'm going to do, let's say I do 4 C-arm spins. And then let's say I do, 10 seconds of fluoro. So that's all that my procedure's done. So my patient dose is going to be, 4 millisieverts. Now, on the CT side of that, if I did the same biopsy and I go in, I do my normal chest tomograph to localize it. I find whatever, let's say I'm doing a biopsy in the lungs. I find the place, the relative center for the location for my biopsy. I center it, and so then I switch my CT over to fluoro mode, and now I turn on and I do fluoro for 10 seconds. You can see how the dose from the CT is roughly 7 or 8 millisieverts. So you can see how in all of these cases, basically the dose from the fluoro mode of the CT scanner is the highest portion of it. That's why the blue line has that angle. The slope is much stronger than the orange line. There's basically no slope to orange because the fluoro dose or dose to fluoro coming from a C-arm is almost inconsequential. Now, if you come over here to that adult abdomen, you remember over here, this curve was much higher when I did the cone beam spin on my system, on my C-arm system. Let's say I did 3 or 4 cone beam spins plus 10 seconds of fluoro. In this case, the CT scanner down in my conventional CT scanner, even though I'm doing 10 seconds of fluoro, which is a high value relative to a 5-year-old, to an adult, it's actually a lower value. And so this is kind of just a model I built so that I could tell so if the interventionalist came to me and says, hey, I want to do 5 spins and I'm probably going to do maybe 30 to 45 minutes of fluoro, just if for whatever reason they kind of had a clue of what they're going to do. I could basically tell them, all right, well, if you're a 5-year-old, then I would go do that I would do that on the interventional C-arm without a question. If I was doing that, if I was a large adult or big adult, then I would say I'd go use your traditional CT scanner. Now, this is just an example of the actual, because I put the MOSFETs in all the organs. Here you can see the actual organ doses. Now, as you change your field of view, you can see that the dose, let's say here in the lungs, I go from a large 20 centimeter field of view down to about a 2.5 centimeter. As I cone down, you can see the dose to the organ drops drastically. And that is true for every organ I measured. Some organs, however, just didn't really change. The doses were already low to begin with. So this is where you see that the CT itself, when you do just the normal helical motion, the helical scan of say the chest or the abdomen pelvis, the CT itself is generally pretty low. And the reason behind that is because of the tube current modulation, which we talked about many weeks ago. When the C arm spins around the body, it does modulate. Every angle will be a different MA, but the difference is the field of view is this big versus on CT, it's teeny. It's only a couple millimeters wide. And so the CT scanner can modulate much, much better. That said, the doses are getting much better. They're much more equivalent today. So CT acquisitions on a C-arm fluoro units are higher dose on average than the traditional CT scanners. CT fluoro is a higher dose than C-arm fluoro. Obviously, you get more information though. And so that's one of the benefits of if you are going to do fluoro on a CT scanner, well, at least you have more information. You have 2D versus 3D information. Whereas as, excuse me, as everyone knows, and forgive me, I don't know why my image is covering up my text. I'll fix that before I send it out to you guys. But obviously you've all seen fluoro images. There's a lot of anatomical noise because it's a superposition of all the anatomy in one two-dimensional image. Whereas obviously in CT, we flip it on its head. So even though the traditional CT scanner, it will have a little bit more dose in the fluoro mode. You just get much more information. So typically you go faster. You're only working for a few seconds in CT fluoro mode. Whereas you might be working for tens of minutes in a traditional C-arm fluoro mode. All right, so let's shift gears. So we just talked about dose optimization for traditional fluoroscopy, for cone beam, spin CT in the fluoro suite. Now let's just talk a little about dose diagnostic reference levels. So this is data that Dr. Panrutai gave me to look at. And so this is your data. This is Thai data. You guys have made great strides with the first initial review of your various different locations, north, central, northeast, and south. So the kind of major areas in Thailand. You looked at about 14, just shy of 1,500 cases. That's wonderful. So what I did was I looked at your data and then I went out into the literature and I just so you guys have comparisons. I'm sure you did the same thing. This is not meant to say you're doing bad or you're doing good. This is just meant to give you a way to compare things. So the first question that I have, and this is something I would ask you to go back and consider, is your units listed here as milligray centimeter squared. I'm sure that's true. I'm sure you wrote them correct. But when you compare their units, gray centimeter squared, if I do the conversion here, so make these gray centimeter squared, when I look over here, let's say 242 milligray, that would be 0.2 gray centimeter squared. So that would put you guys down here at the near zero. So I think there's a discrepancy in the units. So that's one thing I would just consider looking back and making sure that's not milligray meter squared or gray centimeter squared. Assuming these were the same units, then if you just do quick comparison here, you guys got right here in the 3D mode, 242, and the average is less than 400, but 242 puts you basically at Korea, about the equivalent to Korea. You're lower dose than US, so you beat us. Lower dose than Spain, both their measurements in 2008 and 2016. It's equivalent to, or maybe a little lower than Germany, and much lower than Switzerland. Everyone's doing better in Switzerland. So anyway, here's just a couple, aneurysms. This is, in my summary, I'll explain a little bit more about this, but you guys say embolization, they talk about aneurysm coil embolization. It's difficult to know exactly what everything is. Here, I'll come back. I'm going to show you data from a variety of different countries, and what, the procedures that they chose to use to calculate DRLs, you're going to see is different from country to country to country. which is fine. Every country should pick their main procedures and collect the DRLs for that, because that makes the most sense for their country. But when you go to pick those procedures to collect the data, you need to be as specific as possible, because if you say embolization or aneurysm, there are a lot of different types of procedures that may encompass that. And so for example, here in your neuro, you guys list embolization of intracranial aneurysm. So that would be comparable right here, aneurysm coil embolization. And forgive me, I don't know why the image didn't pop over here. I'll fix that also. I'm like 3 for 3 or 4 for 3. I'm striking out. So in this case, DRLs, you guys are roughly, assuming this is gray centimeter squared, 823. And so you're a little bit higher, assuming this is the same aneurysm coil embolization that they're talking about as you. It very well may not be. And so when you compare your DRL at 823 and their average is a little less than 400, you might be comparing apples and oranges. And so it's hard to say. That's the hard thing about comparing. You don't necessarily need to compare DRLs from country to country. You really don't. But we typically do, just to give us an idea of kind of where we're at, to gauge a way to say, are we doing okay? You may as a country have a DRL set for a particular procedure, but as you can see, like Switzerland, they may, compared to some of their neighbors, such as Germany, there's no reason why probably they should probably lower theirs. Anyway, so here's your neuro stuff. Once again, more numbers. Excuse me, to compare. So now just in general, here's this publication I took the data from. It's a good publication. It's relatively recent. And so it's actually from Korea, Dr. Lee and his group. And they looked at themselves, of course, South Korea. And you can see diagnostic reference levels with their mean, mins, and max. Everything listed here for a variety of different procedures. And I'm just giving you this data so you can look at it as a group. I'm not trying to, like I said, I'm not trying to say these are the right values or the wrong values. Here's Spain, their diagnostic reference levels. And once again, look, this list is different than this list. They didn't do anything with Hickman's, for example. Whereas in Korea, they actually looked at Hickman's, Hickman line placements. Looking at Germany, completely different list. And their diagnostic reference levels. And their units of gray centimeter squared. Okay, Thai, this is back to you guys, Thai data. And now we're looking kind of in the cath lab. So you guys looked at CAPS and your air kerma at the reference point. So that's great. Cumulative air kerma. So your diagnostic reference level here at 75 percentile. You guys are doing good. Now let's compare that to Switzerland, if you wanted to. So you got your percutaneous coronary intervention. This is 110. And here you guys are. Whoops, did I get the right one? Let's see where to go. Oh, I'm sorry, I went the wrong direction. Yeah, DAP 110. You guys are 82. Sorry, I was looking at the wrong. 1,000 sounded wrong. So you guys are 82, they're 110. So just as an example, you guys are, you're a little lower. That's great. Here's some Finland, and their DAP is 75, so they're just a hair lower than you guys. So you guys are in the ballpark. That's awesome. You guys are doing great. So Thai DRL values are in the middle of the international data, not too high, not too low. My comment to you is just check. I would recommend, as you noticed, all of the publications, they typically use gray centimeter squared. If you want something that's easily viewable and comparable to everything else in the publication, you may change your units over to gray centimeter squared. So what do you compare? Now, like I said, it doesn't have to be that you're comparing the same thing that internationally everyone else is comparing, but maybe you pick at least one procedure or a couple of procedures So it's just a way for you as a barometer, as a measure, as a gauge to know how well you are in Thailand compared to maybe your surrounding neighbors, India, Korea, China. You can just kind of look at the local ones, and obviously on the Indochina, how everyone else is doing around you. All right. I'm a couple minutes over, so I'll kind of go through this a little quick. So let's talk about the last thing is alert levels. So diagnostic reference levels allow you as a country to help gauge everyone to make sure as a hospital system in your country that you're all basically doing about the same dose. Now, it doesn't necessarily mean that everyone has to be below the diagnostic reference level, but it's a point where everyone can try to get better. Now, what about at your local hospital? Now, how do you know that the procedures you're doing, how do you know what is an appropriate dose level or not? And so you need to set up quality control process and set up alert levels. So if you're doing a particular procedure, that procedure may have an average dose across all of your patients for all the years that you're doing that procedure. And if a patient pops above, if one patient is above that, you're going to want to go in and kind of ask yourself, why did that patient get more dose than the average or the typical, the expected? It might be that that was a trainee and they just didn't quite know how to do it, so it took them a lot longer. That's fine. That's great. It's an educational, it's a time for us to educate. Or the patient was very difficult, or who knows, the patient may have been exceptionally large. And there's just a reason maybe that that dose is higher. And so you want to set alert levels so you can investigate the few cases that do float to the top so that you can keep your doses mostly consistent year to year. It's good for your patients. It's good for you. Now, most hospitals will set their quality control levels at the tissue effect level, 2, 3, maybe 4 gray. Now, I would say that is okay if you're doing interventional procedures. But if you think about the fact that you probably do in a very busy, large academic type hospital, you're probably doing tens of thousands of interventional cath lab procedures a year. Only maybe a couple hundred, a few hundred will exceed this 2, 3, 4 gray range. And so if you set that as your quality control alert level, then you're really not able to check adequately how well as an institution you're doing, because you're only doing it for just a very small percentage of your procedures. It's definitely not appropriate to use the tissue effect level, the 2, 3, 4 gray, if you're setting alert levels for kids. We, as in a pediatric centers, rarely even get this high for the more complex interventional and cath procedures, but especially in radiology, when you're doing VCUGs, video swallows, enemas, all that kind of stuff, you're never, ever, ever going to get close to 2, 3 gray. I hope you never do. If you do, you did something probably wrong. So we need to set quality control levels that are specific to your hospital and that are reasonable for the procedure. So I'm going to share you how we did it at our hospital. And we created a mathematical model so that you could implement it at your hospital if you were interested. It's something that we're publishing. Hopefully it'll be finished publication real soon. So what we basically did is we went in and we looked at all of our procedures, GI placement, tube placement, VCUGs, et cetera, et cetera. We did it for regular radiology, our tilt tables. We did it for interventional systems in the cath lab, the IR lab. We did it for our mobile CRMs. We just hundreds of thousands of data points, and we did some statistics. So let me share how we built this process and how you could use it if you were interested. So one of the things we wanted to do is we created a simple equation, which you see here. And what this will allow you to do is to take your data and you can convert it to our data, and you can use all of the statistics that we've calculated. So UA may not have this many patients because you might not be a pediatric hospital. And so you may not have tens of thousands of patients that do VSS or VCUGs. So if you try to do your average on maybe 200 or 300 patients, the statistics just won't be real good. So we have really good statistics, but this value, this absolute value, you know, the y-axis might not look anything like yours. Your doses might be higher or lower than ours. And so you need to scale your doses. And that's what this equation is. This equation will allow you to scale your doses and our doses so that you can set an alert level that makes sense for your patient dose values. So you'll need to know a patient thickness, on average patient thickness. You don't need to know exactly, just a good ballpark estimate. The M value and this S sub alpha are values that are in some tables and they're coming in the next slides that you'll just look up. And this C value, the C hat, which, forgive me, that's a typo. I shouldn't say Z, it should say C hat. That's an intercept value. This is the value that you're going to use to scale your doses so they match ours. So you can use the equation. And what we did is we set up our alert levels at 5% and 1%. So only 5% of all of our procedures, when you look at all the statistics, when you look at all of the doses, that only 5% of them would be over, obviously, the 5%, and only 1% of the procedures would be above the 1%. So we're not talking about an alert level that'll trigger every day. It'll probably trigger maybe a handful of times a month or a year. And so what you do is you use this equation to come up with to scale your doses so you can use our data. And what you do is you take the average dose from an average sized patient, this X average, and you apply it to this equation. And so for all of the different, C-arms, various different fluoroscopic systems, I have these plots here. They'll give you, if you want the 50th percentile, the 90th percentile, 98th percentile, whatever you want. So the 5%, the 1%, whatever you want for your alert level. And this value right here is going to be somewhat equivalent to your DRL. Not that it is a DRL. And I'll give you an example of how to use this. Now we grouped this, these are C-arms, low, medium, high. It's hard to necessarily say which procedure is quote unquote a low dose procedure versus a medium versus a high. We had to just make a relative guess at that. You would just have to make the same guess. If you consider it a medium dose procedure, you would use these fitting functions in the medium. What makes probably more sense when you're looking at general fluoro, you have like your GIs, your VCUGs, all of this. And then here's our data here. I'm not going through every slide because every slide basically is the same thing, but for just every different machine. So for in the interventional, we have the angio and neuro stuff, abdomen and MSK, and then our really low dose stuff like PICS, line stuff. And here's the data from that. And then cath lab, same thing. We have the diagnostic imaging when we do in the cath lab, and then the low, medium, and high. And here's your quote unquote low, medium, and high procedures and all the fitting functions. All right, so I gave you all of that data. So when you have my actual PDF of my slides, if you wanted to apply this, here is the slide that'll tell you how to do it. So we'll step through this one a little quicker. And then if you need all the data, it's there. So assume an adult facility calculates an average cumulative error curve at the international reference point for a average size patient. Let's say their patient at population is about 25 centimeters AP thickness. And the average output, that error curve value for a GI study is 20 milligray. All right, so it's a GI procedure. So I'm going to use this data here, and I'm going to use this equation to scale this facility's data to ours. So I know D average, because I looked it up at the facility, is 20 milligray. And M value comes from right here. X average is their average patient thickness, 25 centimeters. So I do the calculations, and it comes up with a scaling factor of negative 2.104. Now I want to create an alert level at the 98th upper prediction level. So that means the 1%. Remember, 98th, if you think of a bell curve, you got 1% here, 1% there. So we're thinking 1%. So only 1% of all data would trip at this level or trigger this level. So I have a 2-year-old toddler. So this patient is now only 12 centimeters thick. So if I go over to my equation from the very beginning of the slides, I have the M value, which is here, the X nu, this is my 12 centimeter thick patient, 12, plus S alpha, which comes from right here. S, the alpha is my intervention level, so I want 98%, so I'm using 0.3. If I wanted to do a 5%, I pick 0.5 or 50%. It'd be 0.7. So whichever value, in this case, I'm doing 1%, so 0.3. And then that C hat, remember, this is your data. You know your data for this 25 centimeter thick adult. But what I really want to do is set my alert level for my kids, my pediatric patients. So I take that, it's a negative 2.104 scaling factor. I plug it all in, I do the math, and it comes up with a 6.1 milligray alert level. So for a GI study, only a 1% of the patients will typically pass this level. Now, this assumes that the dose that you would use on this larger patient will scale for the smaller patient, which is a typical assumption because your machine changes as long as the auto exposure is the same on the machine from small to big, you would expect it to scale. So now you could do the same thing for a 25 centimeter patient. If you want to set an alert level, you just do the same thing, get the M slope times the patient's thickness, 25. You're doing it for the 1%, 0.3, and then your scaling factor, you already calculated. So the alert level now for a 25 centimeter person getting a GI would be 87 milligram. So you can see how the alert levels for non-interventional are going to be a lot lower. That said, that doesn't necessarily mean we're going to be checking every one of our exams. These values represent the upper level of what you typically do at your hospital. So a quick summary, the skills of the fluoroscopist, the interventionalist, they're the ones that typically affect the patient dose, so the usage of the machine. So we want to initially set up the protocol, the parameters, so that when the interventionalist, the fluoroscopist walks in, they'll use the system and they'll be comfortable using it. And we know it's properly set up to get the right dose, pulse, the right dose to the detector, all of that. We want to teach everyone to make sure they use proper geometry and setup. We want the largest source to the patient distance. In other words, keep the table and the patient as far away from the source as possible. Small patient to image distance, so keep the detector as close to the patient as possible. We're going to do our best on a rotating system to minimize the oblique and lateral angles. Longer path lengths through the patient obviously increases the dose. We want to do our best to collimate as much as possible. And this has a lot to do with what we talked about last week, that virtual collimation. And also just means we're reducing the area of the patient dose. So it reduces the overall risk. We're going to use pulsed as much as we can and use the lowest pulsed as much as possible. We're going to do the least amount of imaging with fluoro as we can. So keep our foot off the pedal. Use as much as we can the last fluoro hold and last fluoro loop. And do our best to limit the number of DSAs and cine runs because those are really high dose procedures. Not procedures, techniques. And then of course we just watch. We have the cumulative air kerma at the reference point displayed on the monitor. So as we kind of talked about in our last Q&A, you just keep an eye on that to make sure the doses aren't creeping up too high. Training is very important. So we typically, at least at our hospital, I don't know how you do it, but this is just a recommendation. We always do onboarding for all of our new technologists. We make sure they're trained on the technology at the hospital. So they know how to do fluoroscopy. That's why they went to school. But they may not have used a Siemens or a GE or a Canon machine. So they just need to be trained. So they go through a training, an in-person, hands-on training, and then they do an online PowerPoint that's just on the web at our institution. Another thing that is something that we do here in the US, I'm not certain if it's required in Thailand, but there's credentialing. So any physician that wants to be the one that pushes the pedal, they're the one that actually does the beam on to the patient. They have to be credentialed to know how to operate a fluoroscopy system. This requires hands-on training. They have to do a 1-2 hour, they have to do a one class for at least an hour where they go in, they're taught all the buttons and how to reduce and dose and all the stuff we've talked about. And then annually they have to do an online module. Now, if they're not credentialed, that's fine. They can still be in the room. They can still tell the technologist how to, beam on, beam off, move this, do that. The technologist does just runs the machine. So we talked about diagnostic reference levels, and we talked about the need to set up quality control and alert levels. Those are independent of each other. I think they're both very important. And the DRLs will act as that upper threshold and a goal for all hospitals to meet. And the quality control will allow you as a hospital, as a group of radiologists and physicists and technologists to constantly make sure patient to patient, day to day, your systems are always safe and consistent. All right. Once again, I apologize. I went a little over on that. So we'll see how many questions we have now.
Thank you so much, Sam. One thing that I noticed from your lecture is you like a lot of number and formulas and mathematics.
I did that for you, Tanya. I knew you liked physics, math too.
Thank you so much. So there were 2 questions from the last session that carry on to this one. I forgot to ask. So I think it is about the thing that we talked earlier on the actual on the screen that show the DAP or ACURMA compared to the actual calculations. So the first question is for some neurointerventionists, some neuro IR procedure that need to do the cone beam CT or 3D DSA, is it okay to use the dose report from the machine?
The dose report at the end.
At the end. Mm-hmm. So that may be the same thing that we talked earlier about the dose and the actual calculations from the physicist.
Yeah, that's a good, that'll get you close. So it'll tell you the total value. So if you're doing spins, if you're doing fluoro, you're doing DSA, you're doing a lot of complex stuff. Mm-hmm. The cumulative air kerma is going to always, that will collect the entire time. It's the fluoro time that might not be the same. And that's why fluoro time is usually not the metric you really want to look at. So cumulative air kerma will be a total number for everything you do in that procedure. And that, let's say it's 5,000. And that's the value at the end of the procedure. You look at and go, oh, 5,000. You would say, hey, call up the physicist. Let's do a dose calculation. Let's just make sure everything's okay. And so they would come in. The physicist would get the patient data. They'd probably say, hey, how tall was the table? Or how tall are you? One of the two. And then they could be able to go back. They would take that dose report and go do the calculations. So yes, it's okay. That dose report at the end is actually very important. I would highly recommend, you always archive it. It should be collected. If you have a policy where you send some information to your PACs for reading and diagnostic, I would always at least archive the dose report. That's just a good way to, in case a couple weeks later you go back and you say, hey, let's do a dose calculation. The interventional machines themselves, when you do long, big, complex procedures, the hard drive just fills up. And so that's why you don't go see hundreds of patients on those machines. Usually you'll maybe see, 20, 30, 40 patients on it, and then they start falling off the machine. They start getting deleted. So it's really good to auto archive those dose reports, usually to PACs or someplace.
Yeah. So does it mean we don't need to do the calculations in every patient unless the number go high above the standard number or something that we set it up? So that's why we need to contact the medical physicist to do some calculation and get the actual dose right?
Yeah, and that threshold is something that you as a hospital need to establish. As an example, at our hospital, we chose 5,000. So 5,000 milligray, and that's something that me as a physicist, we have a safety officer, a radiation safety officer, and then we had our manager of IR, the physician, and the manager of the cath lab. And so we had a group come together and we just looked at the data. We said, oh, we've had in the last year, we've had, I don't know, let's say 10 patients with over 3,000 milligray and none of them had any skin reaction. And we had 1 or 2 patients at 5,000. They still didn't have skin reaction, but that's a good safe place to put a threshold. So that's why we chose that. You as a hospital may choose lower. I mean, it's really, I would just recommend you look at your data. And if you're not collecting this data, start doing it now. And you'll start to see, just as you log in, how many patients will surpass a certain level. I know as Thailand right now, they're starting to distribute the radiation dose monitoring software. That's great because the dose monitoring software will help you do this because then you can just run reports really quick and easy.
Yeah. So the follow-up question is about how to record the radiation dose in case that the study that we do the cone beam CT or 3D DSA. So should we use the summation dose report from the machine or do we need to do the calculation separately by the physicist? So the answer is it going to be the same answer, depend on the threshold?
Yeah, it really depends on the threshold. So if your cumulative air Kerma value exceeds your threshold, then you look at all of the data together. You'll look at your fluoros, your DSAs, your spins, you look at all that and you do your calculations from that. If you don't get to that threshold, even though you did a lot of spins, even if you don't get to that threshold, I wouldn't worry too much. So if you think about the spins you just bring that up as an example. The nice thing about the spin is it actually is distributing the dose all the way around the patient. So when you consider the skin, the spins actually don't put a lot of dose on the skin because it spins it around you. It averages it out. The areas that you can get into a lot of trouble are doing a lot of cine runs or DSAs, obviously, because you acquire the image for the mask, and then you acquire the image when you inject the contrast in it to do the subtraction, and these tend to be pretty high, a little bit higher dose values, and so you're basically acquiring 2 images to do one thing, and they're a little bit higher dose so that the noise is lower, and so those can be kind of high dose. But like I said, if you're not crossing that threshold, I wouldn't worry about doing the skin dose calculations.
I see. So on one slide that you do the comparison between the Thai data compared with the benchmark from the other country, and you mentioned about that we need to check on our unit. It's like a milligray or gray per cm square. So I was wondering because I believe that we got that number from the screenshot. Not the physicist that calculate that thing. So I was wondering that what do we have in the screenshot? Should it be the same as the benchmark to show that? Yeah, because I don't think we can do some conversion of formulas to convert those numbers. That's gonna cause more issue for us.
Yeah, and so let's see. Do I have? Okay. Oh, sorry. Let me pop off here. Oh, actually, I think it's in my previous talk. Let me pull my other talk up. So so for example, my machines, the units are in milligray centimeter squares. So, but let me show you my dose report. As soon as it pops up, the value is much higher than your value. You can, let's see.
ทางทีมที่ทำอยู่ที่ช่วยเก็บข้อมูลของทางอินเตอร์เวนนะคะมีคอมเมนต์ไหมเอ่ยว่าเราใช้โดเราเก็บหน่วยถูกต้องไหมหรือว่าอะไรไหมคะเดี๋ยวจะเปิดไมค์ให้ค่ะยกมือก็ได้
Can you see my screen? Is it still presenting?
Yes, we can see your screen.
So you can see here, my cumulative cap or DAP, milligray centimeter squared, is 22,000. So that would be, if you, obviously if you move the decimal over 3 for gray, that would be 22.7 gray centimeters squared. And so your numbers were just, let me, nope, this one right here. There we go. Milligray centimeter squared, your numbers, see, they're not, I would expect that to be 24,200 or something.
I see what
if that
you're
was
saying.
milligray, yeah.
Okay, and on like the benchmark things, they use gray. So
They
which
use,
means
they
gray
use
per, centimeters
gray
square.
centimeter.
Yeah. But
You
I
could be
don't-
right. I mean, I would just say go back and double check.
Okay.
And you do not need to. You don't have to compare them if you don't want to. But as I did really simple here, I mean, if you got all of your data was in milligray centimeter squared, and so your numbers were 22,700 or whatever, that would say that's your average. Well, if you wanted to, you could simply to change it to gray, you just obviously do a little bit of math, and you could make that 22.7 gray centimeter squared.
I see. Yeah. So the next question is about the cone beam CT for the dental cone beam CT. Do we also check the dose reading?
You'll never get high enough on a dental. You can. The dental cone beam will still have the same air kerma and cap or DAP, it will. But by way of effect, tissue effect, not an issue. And by way of like organ dose, really the biggest one that you're considering is your thyroid, from the scatter down to the thyroid. And thyroids are sensitive, but they're not the most sensitive organ. And so risk and tissue effects, those two separate things, are not really big, and especially in dental. So I would track it. And if you want, I would do a diagnostic reference level. I think it's important so that everyone, because dental is the one thing, maybe intraoral, which is more uniform. Dental is something everyone gets exposed to, right? Typically once a year, once a couple of years, they're going to go in and they're going to get at least 4 images of their face. And so they're really low dose. They're really low. We're talking 10, maybe, or I think it's maybe 10, 15 microsievert. I mean, it's equivalent to a background radiation dose per day. So it's really low. But if you're getting it every year of your entire life, then you want to make sure the dose is good. You don't want to be overdosing every patient in dental. So though the doses are low in dental, you still want to get diagnostic reference levels to make sure everyone in Thailand is, doing great, doing good.
Yeah. So next question is about can you explain more about the useful necessity of those structural report, which we'll use for PSD calculation?
The dose structure report. So in this case, so there's 2 reports that are presented at the end of every procedure. There is the dose capture, the dose screen. This is physically a DICOM image. And this is good because you can visually see everything here, and you can take it and do all your dose calculations. And then there is a structured dose report that actually you don't physically see, but when you have your dose reporting software, that's the thing that you'll send your structured dose report to your software. And there is a lot of information. So if you're comfortable looking at the DICOM information, so you go in, you open up the image, and you look at the DICOM information, it will tell you everything. It'll usually tell you angles, it'll tell you dosing, it'll tell you dose per angle. If you've ever looked at a structured dose report, a DICOM report for a fluoro, it is hundreds of pages long, because every time you step on the pedal, it creates something like 2 pages worth of data. And so it's something that you probably as a physicist or a technologist would not want to look at, because it's hundreds of pages of data. But if you have a software out like Radiometrics or the software that you plan to do for your dose tracking, it will collect that and it'll find all the information that's important, and it will store it in their server so that you can run reports really easy. So when you get that software, you want to send this report that you see on my screen, this report, the dose report, goes to PACS. That's something that I would highly recommend you guys archive that in some place like PACS or wherever you are. And then the structured dose report would go to your dose reporting software.
I thought that we should send those like the last page of the dose report to our archive in every patient, because we put the radiation dose to the patient. That is like a must to do.
Yeah.
Right.
And as a radiologist, oftentimes, or an interventionalist, they're going to put that in their report, but it won't be as complete. They might say the cumulative dose and the patient got blah, blah, blah milligray. But having this part of that study on PACS, we can always go back and whenever we want. And then you could look at all of these 15 or so different runs. And anyway, I highly recommend you make sure it's archived.
Yes, sure. So next question is about the dose metrics. Do you recommend to setting up the DRL or QC alert level? There should be CAK or DAP or fluoro time, or only the DAP alone, or ACRMA alone is enough. So if the multiple metrics are required in the clinical practice, how we prioritize which one is the most important?
Yeah, it's a long list, isn't it? There's a lot to do here.
Yes.
So for diagnostic reference levels, I would recommend, as you actually have already done in Thailand, you guys have already started to collect. In this case, in this example right here, this is CAP or DAP for your interventional and your neuro. And then for your cath information, you did both CAP and DAP and the cumulative ACRMA. So for diagnostic reference levels, I'd recommend actually doing those two things, CAP and ACRMA. I think those are very important. They're two different numbers that can be used two different ways, as you may recall. CAP, when you apply the correction value, can give you an estimate of risk, stochastic cancer effect. Since the ACRMA, when you do that equation that we talked about, that will tell you the skin dose. And so that'll tell you the likelihood of an effect. So they're two different things. So now the next question was, what about, what should you do on your quality control? So diagnostic reference levels, that's at the national level, right? Everyone's going to send that off. You guys in Thailand is going to collect all that data. Dr. Panrutai and her group's going to process it, and then they're going to send out these numbers like you see here. And then as a hospital, you're going to try, do your best to maybe get below that. But for quality control, you're going to look at every one of your studies done every day of the year. And some of them, like you saw, in my examples, when you look at my patients, so let's look over here, we'll just zoom up, VCUG. So the vast majority of my patients are under this green line is the 5% and the blue line is the 1%. The vast majority, so 99% of all of our patients are below this. This is actually, I think, 2.5 years worth of data. So in 2.5 years, we had 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, let's say maybe 15 or 20 patients. So not that much. But for us, this is something that's important to track because we want to know why those values, why did this patient right here, a teeny little kid, why did he get, or she, why did they get probably 10 times the radiation dose as all the other kids? There's no reason for that. And so that's why we set up these alert levels. These alert levels are established using ACRMA. We only look at ACRMA for alert levels. And why is that? I don't want to do all this tracking for two numbers. I eat both. An alert system is only there for you just to go investigate. And so you only need one value. So pick one of the two. I personally pick air kerma, and air kerma is important to me because that tells me something about risk now. Now is something that I have to worry about. If someone gets a skin burn, they lose their hair, if they have necrosis, ulceration, I need to worry about that now. Cancer is something we need to worry about, but that's just something that it's so hard to predict in the long term. And so CAP is, for me, not that important of a measurement, but that's my personal thing. CAP is just, it's harder to use when I need to make a decision today about lowering the dose or raising the dose to a protocol as a physicist. So the answer is diagnostic reference levels. Yes, collect both the CAP and the kerma, air kerma. For alert levels, I would just do the air kerma, and that's what I'd prioritize.
That's good to me. Yeah. ทางพัชรีหรือว่าทางฟิสิกส์ที่จุฬามีคอมเมนต์ไหมคะที่ช่วยกันเก็บโดสของ IR นะคะอาจารย์เพชรรีอยู่ไหนเอ่ยเปิดได้ไหมเอ่ยหรือว่าหนูน้องตูนหทัยพัฒน์มีคอมเมนต์ไหมเอ่ยเรื่องของตอนที่ช่วยเก็บโดสนะคะหรือว่าอาจารย์อาร์ตนิวโร IR มีคอมเมนต์ไหมครับเดี๋ยวเปิดไมค์ให้ There is one comment. It's the same comments that maybe we need to check on the units when we correct those things, and maybe that is the one thing that we should reiterate to our group when we do like a manual collections. But that issue should be resolved when we have like a dose measurement software and it's like a directly send all information.
Yeah. And that's, I mean, you kind of said it. It's that's the hardest part about doing all the manual collection. At first, that's the most important part to start the process, and you guys have been doing that. But obviously, units, especially CAP. One machine will say milligray centimeter squared. Another will say gray centimeter squared. Another one will say milligray meter squared. I've worked over my career with probably 4 or 5 different vendors, and they've all had different units. It drives me crazy. So so even when all this stuff goes up to your software, hopefully the software, you'll still need to double check this. You'll want to kind of spot check it, but you want to make sure that all the software is getting all of the units correct too.
So does it mean like each vendor have a different unit?
Generally, yes. Yes.
Same or different?
Yes. Yeah. So if you work in a hospital and you have a Siemens unit and a GE unit and a Canon, and you just go down the hallway, you may find that the CAP value is different in every room.
Oh, okay. So does it mean that the software company things should help us when we send those data? They should rearrange to get the same unit.
Yes. So if you look at Radiometrics, all of those vendors put the information into Radiometrics, but Radiometrics has only one unit. So yes, it's a little simpler that way.
Same comments about the unit. So that is one thing that I just know, because initially I thought that we have like each machine has the same unit. Maybe like some manual things that we get wrong, but okay.
Yeah, no, it drives you crazy too. And that's why air kerma is actually good, because it's one unit. It's milligray. Whereas CAP is just different. It just depends on how some people do it. Some vendors do it a little differently.
I see. So thank you so much, Sam, for helping us and give us a feedback on what we have done so far in terms of DRL in the fluoro and also IR, and also giving a lectures for today. Yeah.
I'll make you a deal. I'll come to Thailand and I'll check your units for you. Then we
Yes.
can go get some good Thai food.
Sure. So after the COVID thing is better, for sure. For sure.
Yeah. No, I
Yeah.
appreciate it. So if there's additional questions, like I said, because some people might not have been able to watch today's lecture because they're busy.
Yes.
We can always talk about this next week if we need to.
Yes. And สำหรับท่านที่ดูนะคะไอ้ตัวเอกสารนะคะจะให้อยู่ในลิงก์ที่ท่านใช้ลงทะเบียนนะคะสามารถเข้าไปดาวน์โหลดเอกสารประกอบการประชุมได้ในแต่ละครั้งนะคะแล้วก็หลังจากที่เสร็จเลคเชอร์วันนี้แล้วจะมีลิงก์ส่งไปให้ทำการประเมินนะคะช่วยทำการประเมินแล้วก็ส่งกลับคืนมาภายในวันพฤหัสตอนเที่ยงคืนนะคะเพื่อที่วันศุกร์ตอนเช้าจะได้รับ CME เครดิตนะคะแล้วก็ใบเซอร์ติฟิเคตแล้วก็วันศุกร์ก็จะได้รับลิงก์ของอาทิตย์ถัดไปด้วยนะคะFor the audience who register, you can check on your email or log in to the IAOC website to download the PDF lectures. And you will get a link for evaluation. Please do the evaluation and send it back by Thursday midnight. So Friday, you will get the certificate and also CME credit. And you will get the link for the next week on Friday. And so next week, Sam, we are going to talk about CR and DR, which is a pre-radiograph, which is, I think is like it is important right now in Thailand, as we know that we have the COVID, like the third wave of COVID. And this is like a new variant from the UK, not the original one. It's like a UK variant, which is easily spread. And it also going down to the lung easier compared to the initial strain. So that's why right now we have a lot of patients, not only in the actual hospital, we need to build a field hospital and put a lot of patients together. And we start having so most of the patients, all of the patients who has a COVID positive need to get a chest X-ray as a baseline before having the follow-up X-ray later. And the issue coming to us as a radiologist and technologist, how can we handle those things? To prevent, to protect ourselves from to get infection, because even we have the full PPE coverage, it's still a lot of patient, right? So one idea come to us can we do the open field X-ray? Just put an X-ray machine in the open air environment and call patient to get the X-ray and send them out. So when we have an open air, it less infect to us, right? So any issue that we should be aware of when we want to do that things, any scatter radiation to the environment, to the other people. This is a homework for you, and hopefully you can help us. And the second thing is in the hospital, we come with the idea to do a double glass technique to get the X-ray. So which means we put the patient in the room. And we tell them, okay, you go to the stand to get the X-ray, show them the position that they're supposed to do, and the technologist is outside the room and control things. So which means it's a double glass technique to get the image. So which means, is there anything that we should aware of as a radiologist and also technologists, because there is multiple layers of the glass, or I think it's maybe a plexiglass or plastic or something when we scan when we get the chest X-ray to the patient. So that is it's a homework for you for next week. At least you can teach us, or you can explain us, or you can guide us what we should do in this situation that we're facing with the COVID stuff, and we need to deal with a lot of a chest radiograph on those things.
That's fun.
And
I like.
Yeah.
I like homework. So
yeah.
And I'll make sure to put lots of numbers and equations just for you. Okay, Tanya?
So much. I love the number. So much.
So yes, definitely. I will include I will include that in my talk next week. That was great.
About the technique and radiation dose and how can we deal with those things and check for the image quality. I think because most of the machine that we have is going to be a portable chest radiograph. Yeah.
Yeah, I'll definitely look into that.
Okay. Thank you so much, Sam, and thank you everyone for attending the lectures today. Stay safe, and we think we can pass this the third wave of COVID together. Just wash your hands, wear the mask, and social distancing, and hopefully things gonna be better. So stay safe, and I will see you guys again next week. Thank you so much. สวัสดีค่ะ Bye bye, Sam. Thank you so much.